Namaste and greetings from Nepal. It is a great honor for me to be a part of the band Ophthalmologica. I would like to thank Dr. Vaibhav Sethi for roping me in for this program. It truly is an honor. Well, I've been asked to introduce a little bit about my music. Personally, I started playing the guitar when I was 10 years old. And there was always conflicting ideas in my head whether to become a full-time musician or whether to have another career. But at this point, I'm very happy I'm able to do both. I have a band called the Blue Fret. The Blue Fret plays original music. Our music mainly focuses on folk as well as the Western genre. We have 7 members in our band. And the special feature about our band is that we have incorporated our ethnic instruments. For example, the sarangi and the flute. So when you hear the band, you get a touch of both Western as well as the Nepali folk music. Our band plays in different venues in Kathmandu. And apart from just playing music, we also have established a not-for-profit called Music for Medicine, where we set aside money for this organization. Music for Medicine, what it does, it sponsors music studies for those students who are unable to afford to pay their fees. We also support salaries of music teachers at institutions that are struggling to make the music happen. And also, we set aside money for the free treatment of patients. So this has been going on for quite a while now. I remember the first time that we started raising money for treatment was back when I was a postgraduate student in Manipal. That was, I forgot, many years ago. But with Dr. Biju Raju, Rohan Daniel, and we formed a band called the Donesis, like the Faco Donesis, and we were able to raise money and start a fund called the SRF, which is the Site Restoration Fund. So that has continued even now in my career. So I'm very glad that this concept came together by the 3 of us then, ophthalmic residents, trying to do something with our music. Apart from the music, we have also a not-for-profit organization called Ek Ek Pahila. It was founded during the time of the earthquake, when Nepal was severely affected by the earthquake, in fact devastated by the earthquake. And a group of medical doctors and like-minded friends, we went to these earthquake devastated areas to provide medical services. And it was all on voluntary basis. After a period of 1 year, we realized that we had become great friends, and we thought, why not register these organizations and do the medical services more seriously? Which led me to follow another path in my life, where I resigned as the head of the department of glaucoma, head of the department of research at Tilganga Institute, and started my journey as a volunteer at Ek Ek Pahila. And today we are proud that we have traveled extensively in remote areas of Nepal, where we provide comprehensive health service, not just ophthalmology, but the entire outfit of setting up a small clinic in the remote areas and providing ENT surgery, eye surgery, gynae, and minor operations, sometimes even major operations, working with the primary health centers, dental surgery, and also providing the people there with music. So often the band joins our areas, joins our mission to provide music to the community there. And most of the funds are raised through the Nepalese in Nepal and overseas. So we are very much a Nepalese run organization, trying our best not to depend on foreign aid, but we welcome our friends donating from all over the world, but 90% of the funds are generated through the Nepalese diaspora in overseas, as well as the local residents here. Well, this is what it is, and I think now you should just hear the music that Vaibhav insisted that I come and join over here. And music is something that is so abstract. Some people will like it, some people won't. But I do hope you will enjoy the music, and hope you will be able to come to Nepal sometime and attend our shows. And if not for the music, come to Nepal and I can be your travel guide, and I can tell you something and show you around my country. And yes, so that's it, and it's a great honor, and thank you so much, and I hope you guys have a wonderful webinar.
Don't say hello. You've been away too long. Don't say you need me. I've been holding on too long. Don't you try to make it right. Don't say you want me. It's hard not to fight. But don't you dare say the words that I want to hear. You can't see right through me, but I couldn't care. And at times like these, I try not to say I need you. At times like these, I try not to say I want you. Don't say hello. You've been away too long. Don't say you need me. I've been holding on too long. But don't you try to make it right. Don't say you want me. It's hard not to cry. And at times like these, I try not to say I need you. At times like these, oh, at times like these, I try not to say I love you. Don't say hello. I feel there is nothing a way my life can be. I feel the rain pouring down on me. My troubled mind and soul, it doesn't let me get a hold. A day without you now, it seems like the sun's going down. I try and try to pretend it's alright. The nights are long when the stars don't shine. A new morn was a day behind. I can't understand the way it's out of hand. Maybe you are the reason why. We could try when the nights are long and the stars don't shine. A new morn will show us the light. We can then understand the way it was out of hand. There wouldn't be a reason why. There wouldn't be a reason why. There wouldn't be a reason. There wouldn't be a reason. There wouldn't be a reason why. I got so much going on. I feel alright, I'm walking tall. If you love me, then come right here. Stay with me and make it clear. If you want me tonight, you've got everything going right. I'm in a mood for some moonshine with you every night. So come on, sugar. Can you feel it? Do you feel it coming, honey, baby? If it makes me blue, I'm gonna go. And I got so much going on. I feel alright, I'm walking tall. If you love me, then come right here. Stay with me and make it clear. wanna know if it makes me blue. I'm gonna go. I got so much going on. Can you feel it coming? Ooh, I got so much going on. And oh, Melissa, I can't complain. You are my sunshine in the rain. And I can play a tune on a sleepy afternoon to you. Oh, Melissa, Melissa. Oh, it's true. At times I'm lonely, well that's nothing new. My heart feels weary, dreaming of you. At times I'm flying and I could touch the moon. Your love comes pouring to wash away my wounds and hard and trying times and all the sleepless nights in a world so unkind when friends can't be found. You take away the blues. Oh, Melissa, Melissa. Whoa, whoa, ooh, it's true. And ooh, Melissa. Oh, it's true. मेरो आवाज सुनिदेऊ, मनको कुरा बुझिदेऊ, मेरो साथ हिँडिदेऊ, कहिले नछोड मेरो हात। एक एक पाइला हेर्दा पनि मलाई पछि नछाड, पर्खेर लैजाऊ मलाई धेरै टाढा। तिमलाई सम्झे यही बेला एक्लोपनमा निराश लाग्दा बिर्सेको दिन कहिले पनि सधैँ रह्यौ मुटुभरि भन्न सकिन मनको कुरा। तिमी नै हौ मेरो संसार, तिमीका सधैँलाई आकाशमा तिमी हौ मेरो प्रकाश एक्लो यो जीवनमा तिमीले हौ मेरो साथ मेरो आवाज सुनिदेऊ मनको कुरा बुझिदेऊ मेरो साथ फेरिदेऊ कहिले नछोड मेरो एक एक पाइला
Namaste. Good morning, good afternoon, and good evening. Welcome to the world of Pan Ophthalmologica. Pan Ophthalmologica is not just a webinar. It's a collaboration. It's a collaboration between 20 countries, from Australia to Argentina, from Brazil to Bolivia, from Germany to Greece, where over 100 ophthalmologists all across the globe have come together to share knowledge, share their experience and their challenges with one aim: to learn from each other. Today is the World Sight Day, and we celebrate the gift of vision or the gift of sight. Sight is a beautiful symphony of color, light, and beauty, and it's just like music as it transcends boundaries, languages, and culture. We just heard Dr. Suman Thapa and the Blue Thread Band playing beautifully, and how there's a beautiful harmony and synchrony between music and science. Today, we have over 9 virtual halls with over 20 captivating sessions of ophthalmology, and over the next 2 to 3 hours, I hope you all will enjoy as much as we did to put together this program, and I hope that we see everybody soon, and let us start this symphony of knowledge and creativity. Thank you for your attention. Looking forward to seeing you. Namaste.
Next session, please.
Hello, welcome everybody, and this is the cornea and refractive surgery hall I. I welcome you all on behalf of Pan Ophthalmologica and also on behalf of Arunadar Desai Eye Hospital. And I hope that we have a great session today. We have a host of excellent speakers, very experienced speakers in both refractive surgery as well as in cornea. And we will begin this session today with the cornea with the refractive surgery segment. And I'm Dr. Abhishek Hoshing. I'm working with Apollo Hospitals, Navi Mumbai. And in today's refractive surgery session, we have Dr. Ritin Goyal, Dr. Rushad Shroff, Dr. Vardhaman Tankria, who will be joining us shortly, and also Dr. Tiziano Gibelli from Argentina. Welcome you all speakers. I see that Dr. Tiziano hasn't joined yet, but he will join soon. But we'll begin the first talk, which is Dr. Ritin Goyal. And Dr. Ritin Goyal is a dear friend. He did his refractive surgery and cornea fellowship from L.V. Prasad Eye Institute in India. And he's a prolific cataract refractive surgeon practicing in Delhi. And throughout all my interactions with Dr. Ritin, I've always found him to be a very, very practical person who gives very simple solutions to seemingly difficult problems. And today he is going to share with us his opinion about such similar issue, which is refractive surgery talk about what do you do when you find a patient with a -8 diopter myopia, and then the options which you have in front of you are there. So over to you, Dr. Ritin, and I welcome you all once again.
Thank you. Thank you so much, Dr. Abhishek, and a very warm welcome to all the delegates who are part of this program. I'm just trying to share my slides. Are they visible?
They're visible, Dr. Ritin. Go ahead.
Yeah, and you can hear me as well, right?
Yes, we can.
All right. So today we're talking about LASIK versus ICL in a case where you have myopia of -8. And so why are we talking about -8? I think -8 is right at the cusp of where we sort of struggle to decide one way or another. I think if the patients have a refractive error, myopic refractive error of -9 and above, things become quite easy. ICL seems like an easy choice. We understand what are the limitations of LASIK as we go higher and higher. And in cases where the power is quite low, ICL sort of seems like overkill. So I'm just going to go through a few cases and talk about, the thought process for, selecting the procedure of choice. It's a really short presentation so that we can have some discussion right at the end. Thank you. So what is the advantage of LASIK over ICL? At least in my practice, we do bilateral both eyes LASIK simultaneously. And when I talk about LASIK, this includes LASIK, PRK, any of the topography guided treatments, or even you could include any of the lenticular extraction treatments today. The principles would remain the same, and that's it's about the same, as compared to ICL. So we do both eyes together, and the cost of these procedures is typically much, much lesser as compared to phakic IOLs. And, it's an extraocular procedure as compared to intraocular procedure in case of phakic IOLs. It's a permanent treatment. A phakic IOL is an implant that's going to be sitting in your eye till as long as you don't get a cataract, and then it's eventually going to have to be removed. And it's been very, very popular. I think it's LASIK has been around in India for now close to 30 years, at least PRK from the PRK days. And the number of patients who've had laser refractive surgery is huge. So patients, they come in looking for laser treatments for specs removal, and that is the first line. So just starting with the first case, if you look at this case, there's a lot of corneal thickness. The minimum pachymetry is close to 580. The keratometry is quite steep. However, there's no real risk in these cases. We can see that the cornea is very even. If you have -8 diopters of refractive error, I would happily do refractive surgery, laser refractive surgery. In this case, it's an ideal case with high keratometric readings, very high pachymetry. Patient's pupil is not too big. The patient would have excellent outcome with LASIK, with PRK, or with SMILE, or any of these procedures. Also, you can notice in this case, the AC depth is really low, so we don't really have many options except for LASIK. But what is much more common is that we're looking at patients like this, where the keratometry is not so steep, 41, 42 diopters of keratometry. If you look at the power of treating -8, and the corneal thickness is 533 microns in this case, if you are looking at treating something close to 8.5 diopters, and you make about 100 micron flap, you're doing a 6.5 mm optical zone, you'll be ablating close to 140. You'll be altering at least 140, close to about 200 microns in the cornea. So you'll be really getting close to that residual bed thickness. The percentage thickness is altered. The main catch with laser refractive surgery, if you are planning to do in a flat cornea, is that you lose quality of contrast, you'll lose quality of vision, you'll add to the glare of the patient, and you'll be doing all of this while increasing the chances of you landing up with ectasia. If you look at a large subset of these patients, the patients who would actually do well with LASIK are the ones where the potential risk of ectasia is slightly higher. These are patients with high keratometric readings who would land up with much physiological looking corneas. But also we understand that patients who have high keratometry, they also have a slightly higher risk of having ectasia, since we could have missed out on their ectasia potential before surgery. Now, coming to ICL, definitely better quality of vision. There's no risk of corneal ectasia, that's for sure. Possibility of explant is there. Should we land up with any sort of problem with the implant, we can always remove it. And if you're ending up with a refractive error after ICL surgery, we could always do LASIK. Why is this important? You have to remember that what we are operating here is a patient who's relatively young. We're assuming that the refractive error has come to a complete halt, and these patients have high refractive errors to start with. It's not very common, but it's not uncommon to see a patient who had a -8 refractive error when he or she was 20, 21 years old, and landed up with a -10 or -12 refractive error by the time that they were 30. It doesn't usually happen, but it can happen. And for these patients, a top-up LASIK treatment would be really good. Some of the examples are really easy. Corneal thickness is not there. The cornea looks quite suspicious. There is some amount of inferior steepening. Anterior chamber depth is quite good. These are patients that are suspect for keratoconus, don't really have keratoconus. And we know that these patients will do well with ICLs. I don't think that there's much question whether we should be doing LASIK or ICL. But every once in a while, we would have these patients, you have quite a flat cornea. You're looking at treating -8. You would finally land up with about 35 diopters of mean keratometry by the end of after LASIK surgery. So you would err on the side of doing an ICL. However, you do, in this case, the internal AC depth is only 2.6, even less than 2.6 millimeters. It's not a great case for ICL. The chances of us landing up with glaucoma or cataract sometime in the future are quite high. So it's not an ideal case for ICL. The only other option, probably LASIK, would be much better. I think that there'd be some people who would think about refractive lens exchange, like a clear lens extraction with a monofocal IOL, but or a multifocal IOL, which is not something that I would really favor. I think such a patient where you don't have AC depth, you can take it up easily for a LASIK, even though there's a slight compromise in the quality of vision as compared to ICL. So just to summarize, I think it needs to be decided on a case-to-case basis. I think ICL seems to be a better choice optically. I think LASIK seems to be a better choice financially. Uh, Isolated. So if you're an isolated LASIK surgeon, or if you're an isolated ICL surgeon, means that you exclusively do only one of the two procedures. I think it's a handicap both for you and your patient, because if you're an isolated LASIK surgeon, you're erring on the side of poorer quality of vision or ectasia, increasing the chances of ectasia for some of your patients. And if you're exclusively doing ICL, I think you're doing overkill uh, with a temporary implant, which will definitely have to be explanted some point of time from the patient's eye. So I think case-to-case basis approach is the right way to go forward, and I think both procedures must be available to a refractive surgeon. Thank you. So I'll be happy to take any questions if there are.
Sahil, do you want to start? Do you have?
Well summarized, Ritin. So I think what he clearly said was good anterior chamber depth, ICL, and steep cornea with good pachymetry, LASIK. Question is, when both options are feasible, then what surgeon decides, or what surgeon tries to convince the patient that this is better for you? That would vary from surgeon to surgeon. Let's have a debate or discussion what we panelists would want for a person who is fit for both the procedures with a keratometry of say 44 diopters, refractive error of 8 diopters, and thickness of 540. So traditionally, we have always believed that LASIK, being an extraocular surgery, is a safer choice between the two. But now, specifically last 5 years, I believe that perception is slightly tilting, with people believing that ICL is probably equally safe. Let's have a viewpoint of everyone, whether everyone agrees with this or still believes that LASIK is a safer option.
So let's begin with Ritin's opinion first, I think, because.
Yeah, hi. I'm still audible, right?
Yes.
Yeah. So I think that -8 is right at the cusp of it. I would choose to have to do ICL for most patients with -8, just because the quality of vision with ICL is really, really good. So I can share some of my experience, and we've done a lot of these cases where we had patients with -8 in one eye and -12 in the other eye. And keratometries and corneal thicknesses are very similar to what Sahil had just mentioned, looking at keratometries of 44, 45 diopters. Corneal thickness is quite good. We would traditionally do a -12 ICL in the high myopic eye and a -8 LASIK in the better eye. Patients might even be amblyopic to start with, but every single one of these patients would clearly say that the quality of vision with the -12 eye was much better than the -8 eye. So we have almost exclusively stopped doing one eye LASIK, one eye ICL. And we are quite clear about that the quality of vision with ICL is far, far superior. And the quality of vision does drop as you increase the refractive error. Currently, our cutoff is -8. I only see it coming down further. I don't see this going up any further.
Right. Let's hear out other panelists, Dr. Rashid, Dr. Tiziano. I think he has joined in. If Rashid or Dr. Tiziano, if you can hear us and would like to chip in, that what would be your preferred technique for these borderline refractive error cases? In terms of safety, in terms of vision, I think it's a no-brainer that ICL probably offers better quality of vision if the cornea is not very steep. But in terms of safety, what would the surgeon preference be from your side?
Dr. Roshad, we can't hear you. Yeah.
Hi, sorry, I just missed that. Can you
Sahil,
just repeat?
Yeah. So, Rishit, the question that we are trying to discuss here is that moderate refractive error, -8 to -9 diopters, good pachymetry, 550 microns, good anterior chamber depth, 3.1 millimeters. What would be your inclination when you're trying to convince the patient for either of the two procedures, LASIK versus ICL?
So normally I look at the keratometry also, and we're talking about myopic LASIK, right?
Yeah,
So
myopic 44 diopters keratometry, anterior chamber depth 3.1.
so I wouldn't want to go under a post-operative 36 keratometry. So that would be one of the criteria that I take into account. Other than that, generally it's about the cost to the patient also, which generally puts them towards LASIK compared to ICL. So with about a -8 with a 44 keratometry, I would be reasonably comfortable doing a LASIK as well.
But if the patient asks you that the cost is no bar, then would your preference shift to ICL?
Yeah, then it would, because of the quality of vision generally would be a little bit better with an ICL.
And
If everything is okay in terms of anterior chamber depth and other criteria as well.
and you would believe that long-term safety of ICL in today's world is probably similar or closer. LASIK,
Yeah,
believe really is an extraocular surgery and hence safer than ICL being an intraocular surgery.
that's true, but overall, I think with ICL also we're fairly safe with our surgeries nowadays. I don't think there's a very high risk of glaucoma, or with the central flow, even cataract rates have come down. So I don't really feel that we're unsafe with the ICL, as again we meet the criteria properly.
Yeah, I think I totally agree with Rushad here. Uh, there's really not so much of a safety concern with ICL. I think the main safety concern with an ICL is about the sizing. If we can get it right, and there's a lot of variables in ICL sizing. Very very similar measuring eyes can behave very differently in terms of ICL sizing, and if anything, that's the only one concern that I do have regarding choosing an ICL, and we discuss that with patients. But that being said, ICLs have been around for nearly 20 years now. And if you look at the number of cataract surgeries or the number of glaucoma patients that we've seen with ICL, this is not a RK-like procedure. This is not a, you know, this is not a really bad procedure. This procedure is going to be here to stay. And I think the quality of vision really does justify the added risk, if you'd call it that. One thing about ICL, though, that we've seen is that pupillary diameter is something that can be quite bothersome. In patients who have very large mesopic and very large scotopic pupils, they can have a significant amount of glare with ICL. Once that the pupil dilates to beyond the optic diameter, and then patients can have diplopia on multiple images as well as glare. So that is something that we do analyze before surgery. And with some of the Indian ICLs, Indian phakic IOLs, you can actually customize the optic diameter and order bigger ones. But however, if we have patients with very large pupils, where we are sure that it's going to go much beyond the optic size of the ICL, we're quite wary of doing a phakic IOL. These patients will have glare even with LASIK, but they'll be able to tolerate it much better. That's been my opinion. I'd like to hear from others as well.
We do have our international faculty members also, Dr. Ticiano, Dr. Kamran Riaz. We would like your opinion also about this matter of discussion. Dr. Ticiano, please.
I think Dr. Kamran is here. His video is visible. Dr. Kamran Riaz, please.
think he has joined a bit later now, but I guess he left right now. Maybe he lost the connection to it.
Okay, so I think
Yeah, go ahead, Sai.
so I think we probably should move on to the next topic.
Yeah, sure.
So 546, I would like to introduce Dr. Rushad Shroff. He is a fourth generation ophthalmologist and he is fellowship trained in cornea and refractive surgery. And we would like to hear from him about his approach for flap lift versus PRK for enhancement of residual or regression based refractive errors. Dr. Rushad Shroff, please.
Sorry. Thank you, Sahil, for that kind introduction. Let me just share my screen. Is it visible?
Yes, it is. Please go ahead.
Okay, just give me a sec. Yeah, so I'd like to thank Aditya and Vaibhav for inviting me for this webinar. So I'm going to be talking about the enhancement procedures which we can consider post refractive surgery, whether a flap lift or a PRK is the way to go in this. And I'll just go through the pros and cons of both. So residual refractive error after refractive surgery, although nowadays it's less and less common, it is still a fairly common thing that can happen, and the rates vary between 5 and 28% depending on different literature that you have. You can have regression because of epithelial changes. You can have overcorrections or undercorrections. And then, of course, you can have preoperative high astigmatic errors, which are prone to not getting corrected fully. So these are the etiologies that are there as to why we can have residual refractive error at the end of a primary LASIK treatment. So regression after refractive surgery refers to a gradual tendency to return to the original pre-operative ametropic state, whether it be myopia or hyperopia. And it occurs most commonly somewhere between 3 and 6 months, but can occur in the late postoperative period as well. One of the reasons that has been postulated is the epithelium. The epithelium masks things very well, but it does tend to lead to regressions as well. Decreased flap thickness, stromal remodeling, lenticular changes, where you have lenticular changes which tend to cause a change in the refractive error, and various other reasons have been postulated as well. So the evaluation before retreatment, it's important to have a constant subjective refraction and a cycloplegic refraction done. The tomography and aberrometry should also be looked at, and again, it should be a stable topography that you get. If you have access to epithelial mapping, it is a very useful tool to understand what is happening at the epithelial level, because sometimes these regressions can be misdiagnosed when it's actually a epithelial hypertrophy, and treating that tends to solve the issue. A proper slit lamp evaluation and retinal examination is generally important, as is a dry eye evaluation, because the tear film can often mimic these problems and again lead to a refractive error, which may be a misdiagnosis on our part if we don't take the tear film into account. So suitable candidates for enhancement should demonstrate refractive stability for an interval that comprises at least 2 separate clinic visits. Generally, I do this about 3 months apart. There should be an accurate determination of the residual stromal bed. This is important because miscalculations or misinterpretations can lead to overestimation or underestimation of the RSBT. We should try to use high frequency ultrasound, OCT, or confocal if possible. Confocal is generally a research tool, but it has been shown to be useful in terms of finding out changes in the nerves, which again lead to changes in the tear film metrics. Epithelial imaging, like I mentioned, is important, especially in cases of epithelial hyperplasia. So the regression masquerades, sometimes again ectasia can look like this in the initial period. Therefore, it's important to look at this over a period of time and reevaluate whether you can actually go ahead and treat or not. So the enhancement modalities, you have either lifting the flap, surface ablation, you have you can make a mini flap with the flap posterior surface ablation, and conductive keratoplasty and arcuate keratotomy are not really very preferred options these days. So I'm going to be talking mainly about flap relift and PRK as our two, or surface ablation as our two main things that we do. The flap relift is the most commonly performed enhancement method. There are various different methods. There's also something called the flaporexis technique, which has been described in literature, where you can use a lens manipulating hook to just open the flap edge and then grasp it with forceps and retract and then do the ablation. The reason is that you want to try and minimize trauma to the flap edge so that the epithelium doesn't grow under this to cause an epithelial ingrowth. It's important when we're doing retreatments that the ablation diameter, the optical zone, should be at least the same size as the initial ablation. If you have access to the papers, it would be good for that to see that, so that there's reduced incidence of glare and incidence of decreased contrast sensitivity. So what are the pros and cons of a flap relift? The good points are that there is a high degree of efficacy. It's highly predictable. It's safe for the correction of residual refractive errors in general. However, there is a caveat, because at times this can lead to problems, especially if you have epithelial ingrowths. You can have DLKs. Rarely you can have infections and flap melts as well. Microkeratome created flaps generally are easier to relift for a longer period of time. And in case of issues during the refractive surgery with regard to flap related issues, it's generally not a good option in them to relift the flap. Say you had a buttonholing in a microkeratome flap and a scarring, then that's not really an option to relift the flap in those patients. The surface ablation, it has a high degree of value in a subset of patients. It's useful in patients with thin residual stromal bed thickness. It is important to administer, I at least administer intraoperative mitomycin C for haze prophylaxis. PRK with PTK can be combined for treatment of flap complications. You can do topo-guided treatments for irregular corneas as well. PTK pulses should be evenly distributed to reduce unintended hyperopic shifts. And this is generally important when planning a surface ablation. What are the pros and cons for surface ablation? It's generally safe and effective, particularly useful in thinner corneas where you do not want to again lift the flap and re-ablate. It's an option in those where flap lift is not possible, like I mentioned, corneas which have a little scarring or irregular corneas or which have had flap-related issues. The problem with it at times is you can get postoperative haze, and the tendency to haze tends to be higher in recorrections. Therefore, mitomycin should be used in those patients. In all cases of retreatments, I use mitomycin if I'm doing a PRK retreatment. Should be avoided in patients with lower endothelial cell counts. It's preferable to wait for a span of about a year and a half, some of the literature has said, for nerve function to recover before doing a PRK post LASIK. And then, of course, we have to be a little careful of hyperopic shift post PRK when we do a retreatment. So these are the various papers comparing flap lift and PRKs for retreatments in patients. And what has been shown is that literature says that both treatments were considered to be effective, predictable, and safe in terms of retreatment. So to conclude, enhancement procedures should be planned carefully. It's important to have a stable refraction, make sure the epithelial mapping is proper, the tomography is not changing over a period of time, and then only plan this. Patients with thicker residual stromal beds and recent primary LASIK treatments are good candidates for relift. Patients with thinner stromal beds and LASIK treatments done several years prior may benefit to a greater degree from PRK or surface ablation. Thank you.
Thank you, Dr. Rashad. You have really succinctly summarized both the pros and cons of both the procedures for a re-enhanced pre-treatment or an enhancement of the refractive error. So just had a couple of questions in mind. One is that you spoke about the epithelial hypertrophy being one of the masquerades for either a regression or a residual refractive error. So in such scenarios, how long do you wait, and what do you do for to correct the epithelial hypertrophy? That is one. And part two of my question is, you also talked about the ectasia also in the initial stages mimicking the regression. So in that scenario, according to you, that since you wait only 3 months before to see whether there are two stable refractions, do you think that that is a long enough time to assess whether there is a progression of the ectasia happening over time?
So that was more for looking at, and that's not done 3 months after surgery. I would wait longer than that before I take a judgment on retreatment. Coming to your first question about epithelial hyperplasia, generally, I would put the patient on a lubricant, preferably a sodium hyaluronate-based lubricant, and I do anti-inflammatory therapy with something like cyclosporin or a low-strength steroid for at least 2 to 3 months, and look at what's happening to the surface and the epithelium after that. If still not responsive and still there's a high degree of suspicion regarding this, then we can put them on a bandage contact lens for a little bit of time as well. And that's after a trial of all this. And if only then, if the epithelium is not healing, then we have to consider that that's a hyperplasia that's not responding to treatment. But most of the time, they do respond to this kind of this line of therapy where you use anti-inflammatories or low-strength steroids along with a sodium hyaluronate-based lubricant. That's what I would normally do for that. With regard to your question regarding refractive stabilization, I wouldn't do a recorrection anywhere before at least 6 months from surgery. And very honestly, so far in practice, I have probably just done a couple of PRKs for enhancement. I haven't really lifted flaps, and those were longer follow-up patients actually. So normally I would try to, at that stage, counsel the patient also against going in for a immediate kind of procedure, because nothing is stable initially post-surgery. So it's always more important to wait, reassess these things over a period of time, and then take a call. Even ectasia, I'm not one of the people who jumps into a C3R immediately. I prefer to wait, document progression over a period of time, and then go in with a C3R or a C3R plus an Intax for an ectasia.
Yeah, that definitely clears those points. Also, I would like to invite Dr. Ticiano to join in the discussion, please. If he's here already, we can see that he's online. Ritin, your opinion and your views about this.
So thanks, fantastic talk, Rushad. And I think we finally have Dr. Ticiano, and he's joined in. So Dr. Ticiano, would you like to comment on this first, and then I can go after, please?
Hello, good morning, everyone. Fantastic talk, Rushad. In our practice, we always prefer to lift the flap. We do not do PRK for correction. We have experience of lifting flaps, about flaps of 30 years. So I think it's not a difficult technique to lift the flap. And we do not have experience in PRK over a flap, because we never do that. I think it's better to lift the flap, and that's my opinion.
So I would really agree with Dr. Ticiano right here. The very first LASIK that was done at our center, which was 24 years ago, we did a relift for that patient 20 years later, and it comes off really easy. It's so easy to pick up that flap. It feels like it's never stuck there. And we really like to avoid doing a retreatment by PRK. My personal experience has been, whenever we've done a retreatment with a PRK early, like within the first year, as Rushad had presented, these patients tend to have a lot of subepithelial haze if you're doing a PRK on top of the flap. I think it has something to do with the inflammation that is still continuing within the cornea, which otherwise seems quiet. So relift is something that we prefer quite a lot. And the only doubt is that it's not always very easy to know the corneal the flap thickness before doing a relift. So we're not very sure. So if it's a case that we've operated and we have the documentation and we know what was the kind of flap that we did make, it's much easier to do that. Otherwise, we have to be really safe and be very sure that these patients are not going to land up with a biomechanically unstable cornea. So,
I agree. I agree. Yeah, for relifting the flap, it's very important that we have to do an OCT pre-op so we can measure the flap. And we know that if older flaps are thicker, and when we have thicker flaps, it's more easy to lift the flap because a lot of people are thinking that when the flap is old, it will be more difficult to lift the flap. But in our experience, we think that with thick flaps, it's more easy to lift the flap, to relift the flap. But the OCT pre-op is very important in these cases, so we can measure the flap thickness, and also we can measure the stroma, the residual stroma of the patient. That is very important when we are going to retreat the patient.
So my question then to Dr. Tiziano again is that just like Rushad mentioned in his talk, that there might be cases which are done elsewhere with either like a buttonhole through the flap, which even if you do a very good OCT, you might be able to get a good thickness measurement at some places on most of the flap, but your OCT may not run through the representative area where the buttonhole happened. So in these scenarios, would you still not consider doing a PRK where you are not sure as to what the history of the patient is?
Yes, that's a great question. That's a great question. We try to redefine our residual stroma, not with the OCT, but we can redefine the stroma thickness that have the patient, also with the pentacam. We can see the residual stroma with pentacam and with OCT. I think that in patients that have that do not have a residual stroma, I try to not re-laser that patients. I try to do a contact lens, or maybe if they have a residual stroma that is not good, maybe do not touch the patient. I think it's better.
Thank you, Dr. Tiziano. So now the next talk is actually by Dr. Tiziano Gibellini, and he is from half the world around, from Argentina, and we are very lucky for him to be here. And Dr. Tiziano is working in the Reyes clinic in Reyes and Gibellini clinic in Argentina, in Cordoba. And his talk today is LASIK complications. And over to you.
Okay, thank you very much for inviting me to this great meeting. I am going to talk about LASIK complications. In this talk, I am going to show my personal complications. I am performing LASIK about more or less 20 years ago. I work with my brother. We have a group of more or less 50 surgeons here in our clinic, in our hospital. We also train residents and fellows in refractive surgery. That is not so easy, but these complications are my own complications. I am going to show this one, that is this location of a patient with a trauma. As you can see here, the patient have a trauma with a book and comes to our hospital 10 years later. As you can see there, the epithelium was all over the flap and all over the stroma bed of the patient. We relieve the flap, and in this case, we have to clean all the epithelium. There is a lot of epithelium there, as you can see there. It's not so easy to clean this patient. It's very important to take time. We are doing this over the microscope, not over the excimer laser. We prefer to use the microscope in these cases. And once you lift the flap, we clean the stroma bed with this brush. We always use this brush for our LASIK surgeries too. Then we try to clean the stroma bed. We are cleaning the stroma bed. Also, it is very important to clean the stroma bed of the flap. We apply mitomycin 0.02% to this patient for 1 minute. We put the flap in the good position and the surgery is finished. Another case of dislocation is this one is not, as you can see here, we are using, in this case, we are using the excimer laser slit lamp to localize the flap. This patient was have a trauma with a finger of his daughter. And as you can see here, the epithelium is also grown there in the interface. And we are cleaning the interface of the stroma bed of the patient and also the stroma of the flap. This is another case. The third case of trauma is the same. I will pass this more quickly. Another complication that we can have in our surgery is the free cap. This case is a regular free cap. This is my case. I was passing the microkeratome, the Moria 2 microkeratome, and I have the flap here in the microkeratome. It is very important that you are going to be very calm here. You have to put the flap in the top of the stroma bed of the patient. And here you have to put the epithelium side up and the stroma side down. It is very important that the epithelium is going to be up. Then we try to lift the flap here. We try to lift the flap with our forceps, and then we use oxygen to dry the cornea so we can see the borders of the cornea, and we finish the surgery. This one is a complication that I have about 3 years ago. It's an irregular flap. It's the same free cap, but the free cap is with the borders that are not regular. I am using here a suction ring of 0 with the microkeratome, with the Moria microkeratome. And as you can see there, when I am passing the microkeratome, I have a lost suction and I have a very irregular flap. I lose the suction there, and I have this piece of flap here in the blade of the microkeratome. But the complication is the same that when you have a free cap, you have to put the flap with the epithelium side up and reposition the flap. As you can see here, the stroma bed, the stroma flap is side of the flap is upside. So we are turning off the flap here. And we decide in this case to do not do the laser because the visual axis of the patient was with the irregular flap there. So we wait this patient 7 months and we decide to do a PRK. In this case, we decide to do a PRK. The patient have a myopic ablation of 3 diopters. And as you can see here, when I'm taking off the epithelium, you can see the line there of the old flap that we have there. Fortunately, the patient was 20/20 in the first 24 hours. We have, you can see there the old flap. We use mitomycin here for 1 minute, and then we do the surface ablation. So the management of the free cap, if the free cap is regular, you can do the laser and put a banded contact lens. And if the free cap is irregular, it's better to do not do the laser. And maybe 6 or 7 months later, you can do a PRK, or even you can choose a femto laser treatment. The tips to avoid this kind of free caps, you have to take care about the patients that have keratometries down of 40 diopters in small orbits, patients with decentrated suction rings, patients that have damaged plates, always mark the patient and evaluating the stromal regularity is very important in these cases to decide if you are going to do laser or if you are not going to do the laser. Epithelial ingrowth, this complication is one of the most frequent complications in refractive surgery and also in retreatment surgeries, as we talked some minutes ago. Here you can see the epithelial ingrowth that is very, very centered in the visual axis. So we decide to lift the flap and take the epithelium there. It is very important, the visual acuity of the patient, the location, because if we have an epithelial ingrowth that is in the periphery of the flap, we can control the patient and do not treat this patient. The management of the stria, as we know, stria, we can have micro and macro strias. And to lifting the flap in a patient with stria like this one, we have to have a poor visual acuity, and the strias must be centered in the cornea. The location is very important. The time of the stria is also important, because when we have strias that have a long time, it's very difficult to treat these strias. But when the stria is not for a long time, it's more easy to retreat these patients. We have two kinds of surgeries, epi-on and epi-off. We prefer the epi-on surgery in these cases. Hemo and interface. Here we have a patient with a little bit of hemo that was 2 months with that hemo, and we decide to take it out. I will pass this quickly. This case of a bottom hole, this case is a very nice video that I have. I am passing the microkeratome, and I don't realize that I have a bottom hole in this case. And when I lift the flap, look what is in the middle of the cornea. It is very important in these cases that we have to put the flap down and do not do laser in these cases. I prefer do not do in patients with myopia, even though in patients with hyperopia. It is very important, if you realize that you have a bottom hole in these cases, do not lift the flap, because if you lift the flap, you can have epithelial ingrowth in these cases. This is how we treat this kind of patients with bottom holes. And with femtosecond laser, we do not have too much complications. The most common complication is the OBL, or occlusion bubble layer, is when you have your handpiece, you press the handpiece too much, and the air goes to the periphery of the cornea. And the other complication with femtosecond is the tags that are similar than in flax in femtosecond cataract surgery, that are not so common and are very easy to manage. The last case, this case is a friend of mine. I do laser to this patient with astigmatism, and I have a decenter ablation, as you can see here in the pentacam. The decenter ablation is a very uncommon complication of LASIK, but it's very difficult to treat. Is when we have the optical zone treat and do not match with the visual axis. The main causes of these decenter ablations are bad fixation of the patient, poor collaboration of the patient, the eye tracker is not working good, bad position of the head of the patient, and too much hydration of the cornea. Here you can see the pre-op pentacam of the patient and the post-op pentacam of the patient. The patient was 20/25, but with a very poor quality of vision. Here you can see the higher order aberrations pre-op and post-op. And we decide to do a Cyoptic HD, that is a personalized ablation with the Teneo 2 machine. And as you can see here, the patient, this is the pentacam post-op of the patient, was very, very good and a little bit happy. So you can see here the pre-op pentacam, the post-op pentacam, and the post-op pentacam of the patient that was treated with the personalized ablation. So thank you very much for the invitation. You're all invited to Ophthalmo Córdoba. There is a free virtual and an in-person meeting. And if you have any questions, you can scan my code and I will be glad to respond to your questions. Thank you very much.
Thank you, Dr. Tiziano. That was indeed a very succinct and quick recap of all the complications pertaining to LASIK surgery. And I congratulate you on expertly managing all the complications. I think during your talk, you said it, but probably did not emphasize it much, that the key factor is to keep calm when such things happen and not get flustered, nor get panicky in these situations. Just let your instincts take over because of the training, and you can definitely get through and give good results to your patients. Having said that, going from the various complications of LASIK surgery, I think this is a good segue into our next talk. And in interest of time, we'll restrict the discussion right now. But we can take some questions probably later on. And the next talk is by Dr. Vardhaman Kankriya, who does not require any introduction in the world of refractive surgery. And having trained under Professor Palikaris and also at Bascom Palmer Eye Institute, he has gained intense insight into refractive surgery and is a prolific refractive surgeon practicing in India. He has submitted a presentation which I'll be playing from my own computer, and I think he had also joined and he will be available to take some questions later on. Are you here, Dr. Vardhaman?
Yes, Dr. Abhishek, thank you so much for the kind introduction, and thanks to both Dr. Aditya and Dr. Vaibhav for kind invite.
Yeah, so
I'm sorry that I just landed in Vizag. I have shared the recorded video. If you could just play it for me, please. Thank you.
Yeah. I'll request Dr. Tiziano to stop sharing his screen so that I can share mine, just if you can from your side. Yeah. Is the video visible?
The dilemma and the debate of using mechanical microkeratome or the femtosecond laser as a flap making technology in the current generation LASIK surgeries. I'm Dr. Vardhaman Kankriya from Asian Eye Hospital, Pune, and this is a great honor for me to be part of this wonderful webinar. We all know that it was in 1989 when my mentor, Professor Ioannis Palikaris, performed the world's first LASIK procedure, which completely revolutionized the laser refractive surgery globally. This probably became the first global phenomenon and the first real world accepted refractive procedure, which created magic and made millions of people spectacle free in the last more than 25 years. Professor Palikaris performed the laser on the corneal stroma after raising the corneal flap by mechanical microkeratome and showcased that this technology were giving more stable results than the BRK procedures with minimum amount of healing response and pace. This is a historic video that I'm going to showcase, which is the world's first LASIK surgery. As you can see, this looks very crude right now because this is a historic first LASIK surgery in which all these equipments, including the suction ring, the mechanical microkeratome, were actually developed with the help of in-house physicist at the University of Crete by the team of Professor Ioannis Palikaris. As you can see, this is a flap which is created with the older generation mechanical microkeradomes. Looks a very crude flap with a very wide hinge. As you can see, this was followed by the examinal laser ablation, and then the flap was put back in its place. And this became a new journey in refractive surgery as such, with the development of first LASIK procedure. LASIK became quickly popular because of its advantages over PRK in the form of relatively quick, virtually pain-free, highly accurate treatment, and which could now address wide range of refractive errors, even higher emetropias, without causing haze or regression. More than 41 million people have undergone LASIK successfully around the world, and LASIK is currently the most commonly performed elective surgical procedure on the human body. We all will agree that in LASIK, the most common step is actually the flap making. And this flap making technologies of current generations are in the form of mechanical microkeratome and the laser keratome in the form of femtosecond LASIK or femtosecond laser procedure. The mechanical microkeratome works on the principle of Carpenter's plane. As you can see, there is a suction ring which comes and it stabilizes the globe. It increases the intraocular pressure so that the cornea is stiffened and cannot move away from the oscillating plate. This is immediately followed by movement of the mechanical keratome head, which has applanation plate, which is going to applanate the cornea, which is immediately followed by the oscillating plate, which creates a flap of a decently good quality. As you can see in this case, the flap is then lifted and the examinal laser ablation is applied, and this is again followed by getting the flap back in its position, and the LASIK procedure is over. Currently, there are many different varieties of mechanical microkeratomes which are available in the world, and the one that we use are the SBK Moria mechanical microkeratome. We have been fairly happy with this, and we consider this to be an excellent device in the hands of an experienced LASIK surgeon. It creates a good flap almost every time. However, there are two nagging problems with the mechanical microkeratome flaps. Number one is that sometimes it can lead to unpredictability of the thickness in the tune of minus 24 microns, which has been reported. And it has a high dependency on the preoperative keratometry of the patient and can sometimes lead to visual threatening complications such as flap buttonholes when you have a very steep keratometry, and free caps without a hinge when you are dealing with a patient who has a very flat keratometry. Therefore, the emergence of the femtosecond laser actually created the new era in the current generation of refractive surgery. The femtosecond lasers are basically work on the principle of photodisruption, similar to the Nd:ARC laser. They work in the wavelength of the infrared, which is 1065 nanometers. However, if you compare it with the Nd:ARC laser, the femtosecond laser has a significantly lower collateral damage, about 1,000 times lesser than the Nd:ARC laser that you use for yak capsulotomy. While using the femtosecond laser, ultra-short infrared laser pulses are precisely focused inside the corneal tissue. At its focal point, as you can see, the tissue is disrupted and small bubble is created. By placing these bubbles next to each other in a specified pattern, it is possible to create a cut of any shape and size intracorneally. And the most common application of the femtosecond laser as of today is the flap making technology. As you can see in this animation, when you're making the flap with the femtosecond laser, first you have to applanate the cornea with the applanation assembly, which is slightly different for different kind of femtosecond lasers, but this is immediately followed by these applications of the femtosecond laser pulses, which are immediately followed by more pulses in the periphery, creating a side cut. And once your flap is created with the help of the cavitation bubbles and photodisruption, the flap is dissected, and then the laser application is done with the help of examinal laser. The flap is put back, and that is how a femtosecond laser procedure is performed. Currently, there are a variety of different platforms that are available for flap creation with the femtosecond laser. The one that we use and access to is the Carl Zeiss Max laser, which not only creates a flap, but also creates the smile lenticule for smile procedure. The femtosecond laser flaps have several advantages over the mechanical microkeratome, and the first and foremost being that it is known to create more reproducible flap as compared to the mechanical microkeratome with the precision of plus minus 5 microns. It is also shown to be independent of preoperative keratometry of the patient. Therefore, if you're dealing with a patient who has a flat keratometry or a very steep keratometry, you can still create a very reproducible and a safe flap without landing into flap buttonholes or free caps. And of course, there are no moving metallic parts leading to aseptic shoes and stuff like that. However, in the femtosecond laser, as you can see, when you are actually lifting the flap in mechanical macrokeratome, the flap is pre-dissected. As against that, in the femtosecond laser, you have to dissect the flap and lift it gently. So there is a bit of small maneuvering which is required, but absolutely with the current generation femtosecond lasers. And when you have optimized the energy, the flap lifting is absolutely seamless, and you create a very nice dry bait for your exam laser application. And again, in both this technology, the flap is put back, and that's how you create a complete LASIK procedure. With the help of femtosecond laser, you can completely customize the flap. That means you have a full control over flap thickness, flap diameter, hinge position, and the width, which can be important, especially if you are actually trying to avoid twigs of blood vessels. And also, you would like to have a large diameter for the hyperopic ablations, because the hyperopic ablations are in the periphery, which can be very easily created with the help of femtosecond laser. It is also seen that the femtosecond laser flaps have a much better flap architecture. That means when you're looking at mechanical microkeratome flaps, the flaps are known to be thinner in the center and it becomes thicker in the periphery, called as meniscus shape of the flap. As against that, the femtosecond laser flaps are planar. That means they are equal in depth everywhere, and the edge of the flap can also be customized. So it is widely seen that the flap fitting is much better with the femtosecond laser as compared to the mechanical microkeratome, thus reducing potential chance of epithelial ingrowth, flap slippage, and macro stray, and giving rise to much better and safer outcomes. Femtosecond lasers are also now known to develop more smoother stromal surface compared to the mechanical microkeratome. While working with Professor Balikaris, we have actually done a scanning electron microscopic comparison between the stromal bed quality of LASIK flap made by Schwind mechanical microkeratome as against two different femtosecond lasers, which is IFS 150 and the Wavelight FS 200. We saw that the laser cut with the femtosecond lasers were actually very smooth and of excellent quality, much better than mechanical microkeratome, and we have published this study in the British Journal of Ophthalmology. For the psychology of the patient, the femtosecond lasers have also taken away the fear of the blade, so the patients are more readily accepting the LASIK technology as such. However, with the new technology also comes its own unique disadvantages. The femtosecond lasers are much bigger, they're more expensive, with both initial as well as the running cost of disposables. The flap lift can be difficult for treatments if you want to relieve the flap after many years. And of course, if you are dealing with a cornea which has a significant scar, the femtosecond laser would not penetrate that. So in this circumstances, we still prefer mechanical microkeratome if you're dealing with cornea where there is a significant scar in the periphery, for example. With this new technology, or also new possible unique complications which are possible with the femtosecond laser, they are in the form of cavitation bubbles, which can happen in the form of either opaque bubble layer, or there can be a vertical gas breakthrough, which can happen. There is also a phenomenon called as a transient light sensitivity and the rainbow glare, which has been reported in the past, but I think with time and with the advancements in the femtosecond laser technology, these complications have reduced very significantly. Now, the million-dollar question is that with this proven superiority of the architecture of the flap and the safety, does the femtosecond laser LASIK give rise to much better visual outcomes over mechanical microkeratome? And there have been a variety of meta-analytical studies which have actually shown that the visual quality and the visual quantity is similar whether you're doing a mechanical microkeratome flap versus the femtosecond laser. However, of course, there are potential advantages in terms of the safety and the predictability of the flap thickness when you're dealing with the femtosecond laser flap, and that's why they become preferred. Currently, as far as my preference goes, generally I prefer a femtosecond laser flap almost in all cases, except for patients who have undergone either incisional LASIK, incisional procedure in the past in the form of either RK or astigmatic keratoderms, where with the femtosecond laser you may have a higher chance of vertical gas breakthrough. So we avoid it and we prefer mechanical microkeratomes, or in patients where you are actually having a pre-existing corneal scars, the mechanical microkeratomes are still go-to procedures, and also for the patients who want more affordable procedures or more affordable solution. So I would like to thank again both Dr. Vaibhav, Dr. Aditya, and the Dr. Sethi family for the kind invite. And thank you very much. Wish you all the best. Thank you.
Wonderful presentation, Dr. Vardhaman. Quick question for someone who is setting up a new refractive practice and has invested into femto.
Yeah.
How much do you think would today be essential for him to spend additional 30 lakhs on microkeratome? If someone says and wants that for not affording patients, he or she wants to do PRK, and otherwise for the flap surgeries, femto, do you think that's a feasible option in today's world? Not to have a microkeratome at all?
Yeah, so I think yes. So I think I get your question, and I agree with you that I think current times, if you talk about my own practice, we have almost given up microkeratome, and we do either the femtosecond laser based flaps, or we do surface ablation, or we do smile. So we have moved on to completely bladeless technologies, which are definitely much safer for the patient, and of course for patients who are looking at more affordability, surface ablation is a great tool also, and it works well in a vast majority of patients as well. So yes, if you have access to the femtosecond laser, and a good example is for surface ablation, I think mechanical
and that we have a couple of minutes extra. Quick, your views upon smile versus LASIK, the slower visual rehab with
right.
smile. How does it justify smile over LASIK?
Right. So I will say that probably the smile as a technology has its own advantages, of course, over LASIK, and the most important being for me being flapless procedure, because I think all the flap complications that we have spoken about just in the previous excellent talk by one of our colleagues just now, we definitely avoid all of them if we are actually doing smile. The dryness also in our experience has been definitely significantly lower, and we have also published a paper about it. However, with smile, especially in the beginning, maybe in the first 200, 500 cases, you may experience that the recovery is slower because it's a surgeon's procedure, because you have to potentially dissect the lenticule, and you have to also spend some time in optimizing the energy. Actually, once the energy is well optimized, we have seen that the outcomes of smile are equally actually fast in terms of recovery as compared to the LASIK as well. So basically, in the initial cases, yes, I will agree. But once the laser application is optimized, and once you have actually gotten through a very reproducible method of smile lenticule dissection, and you can do a seamless dissection, I think the recovery is almost the same. Yeah.
Till what cylinders are you currently doing smile? Till what cylinders?
Yeah. So currently, yes. So I think currently we are not treating with smile more than 2 cylinders. We are going up to 2 diopters of cylinder. For anyone who has more than 2 diopters, my go-to procedure is Contura or topo-guided femtolasic. It works very well for astigmatism.
Right. And before we move on, one last question. After smile, how frequently have you needed to use a circle software, lift the flap for say residual stroma or anything?
Right. So basically, as you have correctly said, the circle is most commonly required for enhancement if there is a residual error. Frankly speaking, we have seen, let us say that the enhancement rates with smile to be very low. But whenever we have required, I have always preferred a surface ablation over a circle software flap lifting, because if you are using a circle, you are taking away the benefit of being flapless. So I think doing a surface, and these are usually very small refractive errors, so surface works extremely well for them. The patients also do understand that maybe recovery might be slow, but they still have the flapless procedure intact. Circle I have used actually in one case where we have treated epithelial ingrowth. So basically, there was isolated epithelial ingrowth in the visual axis. This case was referred to us, but then from the small incision, there was no conduct or there was no epithelial fistula. So it was an isolated, probably implantation kind of epithelial ingrowth. So we just wanted to have access to that space. And instead of going through the small incision, which may implant more epithelial cells also, we thought that it is better to create a gap into a flap with a circle.
Absolutely. Okay, thank you very much for your time. And with this, I think we would move to the next session. Dr. Abhishek Koshing.
Thank you.
Thank you. I thank all the participants and all the faculty members for making this a great session. And it was a short but extremely informative session on refractive surgery. And we move on to the next session of corneal on the base of corneal conditions. And unfortunately, Dr. Rasik Vajpayee is not able to join us today. And so we'll be taking Dr. Rishi Swarup's talk first because he's traveling. He also has submitted a video which I'll be playing from my end, and then it's a video presentation. And then we'll take some questions. I think Dr. Rishi has joined already, and he will be available to take some questions. So I'll just share a screen here.
At the outset, I'd like to thank Dr. Vaibhav Sethi and the organizers of if I see these patients in our
Hello. Hi, good evening. Yeah.
first described by Hans as neuralgic vesicular keratitis. Typically, the patients give history of waking up with pain, typically called morning symptoms. But sometimes this can also happen in the middle of the night if you are waking up. And we can have symptoms.
Abhishek, is the audio coming okay, or do you want me to speak instead?
I think, Dr. Rishi, the audio is a bit low. I think the recording is that way. I have kept my speaker volume, etc., to the maximum possible. But if it is audible to other members, I think we can continue this way.
No, it's not very audible. If Rishi can talk, it would be nice. We would love to hear Rishi talking.
Then maybe you can just go back to the beginning.
Yeah, we can do that. I'll play and then the audio here.
Sorry about the confusion. Yeah. Certainly, I would say I'd like to, and you can move the presentation. And the topic which has been allotted to me is the important topic of recurrent corneal erosion syndromes. So, as we all know, recurrent corneal erosion syndrome is a chronic relapsing disease of the cornea, in which patients present with wake up with pain in the morning. And this was first described by Hansen, who initially called it an intermittent neuralgic vesicular keratitis. So not just in the morning and in the middle of the night, anytime the patients wake up with discomfort and they have these recurrent episodes over many years. And help us diagnose the condition rather than the signs itself. The etiology is most commonly some sort of a trauma like a scratch in the cornea, followed by various other conditions. Dystrophies like epithelial brain dystrophy, lattice dystrophy, etc. can also predispose. And there's a whole list which you can see on your screen. In women, the most common cause of trauma is usually injury from a baby's fingernail, and in men, it's usually related to work. So basically, what happens is the erosion can be either primary or secondary, depending on whether the defect in the basement membrane is intrinsic or acquired. Basic pathology becomes insufficient attachment of the epithelium due to dysfunctional hemidesmosomes, and recurrence can usually come on waking up, like I said, and happens during the REM phase when the eyes is opened rapidly, and the epithelium gets sheared off along with the eyelid because of negative suction.
The average age of onset is the 4th or the 5th decade with a slight female preponderance. The interval between the first insult to the first recurrence can vary from 2 days to up to 16 years. Most common symptom is pain followed by watering and blurring. And the most common site, as in this picture, is inferior paracentral cornea, where most often you will see the erosions. So you can see typically if the patient comes with a typical presentation, you see this loose epithelium or epithelial defect. So you can have microform erosions in which you have intraepithelial breaks. So by the time they actually come to the clinic, it's already healed within 1 to 4 hours. Macroform are the larger ones where you can either have loose epithelium or absent epithelium, and they can take up to 21 days to heal. Microform usually occurs because of epithelial basement membrane dystrophy, whereas macroform erosions are usually associated with traumatic etiology, like a scratch, nail scratch, or a paper cut. As we know, that these can predispose to erosions. It's not to say that traumatic etiology alone will cause it. If you have underlying EBMD, that trauma can then become the final second hit to kind of cause that problem. Recurrent corneal erosion is essentially a diagnostic dilemma because often the patients, when they're present in the clinic, the epithelium would have often healed. So you have to basically diagnose these based on the history of recurrent episodes of waking up with pain, watering, blurring of vision, and look at the eye carefully, especially the fellow eye, to look for any intraepithelial vesicles or any fingerprint-like patterns, which could tell you about an underlying pathology which is predisposing to the erosion. And of course, if they come with the classic grayish loose epithelium with intraepithelial deposits, then you can almost be sure of the diagnosis. Unfortunately, the video is recorded at a different pace at which I'm speaking, so I might have said a few more things in the previous recording, but I think it will just turn now. Am I audible clearly?
Dr. Rishi, you're audible.
Okay, great. I'm wondering why this slide hasn't changed. Yeah. So one of the useful tools in addition to the clinical examination is the OCT, and you can have changes in the epithelium, Bowman's membrane, basement membrane, and stroma. Epithelial changes are edema, irregular breaks, undetected epithelial basement membrane, intraepithelial basement membrane, and intraepithelial inclusions. BMBM changes can be thickening, hyperreflectivity, and slit-like spaces. And stromal changes are essentially anterior stromal hyperreflectivity, which could be either because of a scar or some sort of inflammation in the anterior stroma. So the Bowman's membrane, basement membrane is one of the common areas for the changes to occur. So these are the epithelial changes. You can see in the above image, you can see irregular epithelium. In the lower two images, one has an absent epithelial basement membrane seen, and the other image shows intraepithelial inclusions which are showing hyperreflectivity, and the other image and the other arrow shows intraepithelial basement membrane, which again is a hyperreflectivity at the level of the basement membrane. You can also see thickening of the epithelium, which is essentially epithelial edema. So these are the changes at the level of a basement membrane, Bowman's membrane complex, slit-like spaces in the left image, and the right image you can see hyperreflectivity and thickening of the basement membrane, Bowman membrane junction. Anterior stroma, you can get hyperreflectivity like is shown in this image, especially in long-standing erosions or recurrent erosions, you can have scarring like this. So when you're talking about treatment, the goal of treatment is essentially to quickly heal the epithelium and relieve pain. That's the primary goal. And the secondary goal is to prevent recurrences. So the basic principle of the treatment is to improve the adhesion between the epithelium and the underlying tissues by various modalities. It can be either by means of medical management, which is essentially the first line treatment for acute presentations, and surgical treatment is essentially more for the secondary goal of treatment, which is to prevent recurrences and to completely, so that no more recurrences occur in the future. So medical management mainstay is lubricants, with or without topical antibiotics and cycloplegics. You can do patching to help heal the epithelium. Bandage contact lenses are again very, very useful. And it's a good idea to keep bandage contact lenses for at least 6 weeks because that is the amount of time that is required for the remodeling of the epithelial basement membrane. So beyond 6 weeks, if you it's a good idea to try at least 6 weeks. Additional medical treatment can be use of matrix metalloproteinase inhibitors like tetracyclines and autologous serum. These are essentially for more recalcitrant cases to help kind of heal the and to reduce the surface inflammation. Patching can be used as a replacement for bandage contact lenses, but this is probably one of those cases where PCL has a better application because not only does it help to heal, it prevents the erosions from recurring again and again and also provides symptomatic relief. Surgical management is in the form of anterior-stromal puncture, YAG, laser microstromal puncture, excimer PTK, alcohol delamination, epithelial debridement, diamond burr polishing, and in recalcitrant cases, we could try tarsorrhaphy or Botox to paralyze the orbicularis muscle to induce a chemical doses. All of these are essentially to kind of treat the pathology permanently. Anti-stromal puncture is one of the easiest interventions. You take a needle and multiple punctures are done either with a straight needle or you can bend the tip and do it if you want to be safe. And the basic idea is breaching of the Bowman's layer stimulates a more secure bonding of the epithelium to the underlying basement membrane, Bowman's layer, and stroma. Some amount of scarring, but because the punctures are very focal, in between the punctures, the stroma remains relatively clear. So they're not really visually so significant as one would imagine, in spite of having multiple punctures, even if it's in the visual. First, and this can be done in the clinic itself. You can remove the epithelium and then focus your YAG laser on the epithelial basement membrane zone. And this will again create small punctures, which will have the same effect as an anti-stromal puncture. This is more reproducible and the scars are more translucent. So it may be an easier option. Another thing one could do is alcohol delamination, in which basically, just like in PRK, we would remove, or LASIK, we would loosen the epithelium and remove it with a blunt knife or a sponge. You can do the same thing here, use alcohol for 30 to 60 seconds, loosen the epithelium, and then remove it. And basically, you are able to remove the entire epithelium with the basement membrane, leaving behind the Bowman's membrane smooth, so that the next layer has a good attachment to the Bowman's membrane. And studies have shown that the effect of this can be as good as PTK. Of course, because you're removing the epithelium, there will be pain for a few days, but once the epithelium heals, the patient can become quite comfortable and the outcome can be comparable to the excimer PTK, which is a little more expensive procedure. So anybody who has, all you need is an alcohol well and a aerosol sponge for this particular procedure. And in fact, this could probably be the first line treatment even before you do an anterior-stromal puncture, because the efficacy of this procedure is very good. The next line of treatment is essentially excimer PTK. I'll wait for the slide to change. So basically in this, what you're doing is you're removing the abnormal epithelium initially. And after that, we do 10 to 15 microns of ablation so that we are removing the basement membrane, Bowman's membrane complex, and maybe a little bit of anterior stroma. You don't want to remove too much of stroma because that can cause a hyperopic shift and that itself can result in haze. Success rate has been reported between 74 to 100%. And basically, especially if the patients are having erosions because of trauma, the success rate is even higher than compared to with dystrophies, because the basic pathology is still there in the stroma. One could also do a transepithelial PTK, but one has to be careful that the ablation is done at the time when the epithelium is completely healed. Otherwise, if your epithelium is irregularly thick, then you will leave behind an irregular bed, which can have some refractive sequelae and can affect the quality of vision. One can also combine this with a so you could do a transepithelial PRK instead of a PTK and also treat the patient's refractive error, especially if it's a myopic error, it could be done. But if it's a very peripheral erosion, then probably it may not work unless you use a very large optics. The other options of epithelial debridement and using diamond burr, etc., are available. But I think with these other options, those really don't have much of a role. Again, we did study the PTKs that we did for our cases, and we found that most of these patients did quite well. Out of the 11 cases that we did examine PTK, only one didn't have complete resolution and needed additional intervention. So to conclude, recurrent corneal erosion syndrome is a commonly encountered entity in ophthalmic practice. So can be difficult to diagnose, but with proper history and examination and tools like OCT, you can get a good diagnosis. Most of the time, medical management does help, but in recurrent cases where
Dr. Rishi, your voice
can be tried if 6 weeks of medical therapy, especially use opportunity to present in. I hope I was clear. Alcohol delamination, which
wonderful presentation, Dr. Rishi. I think very well summarized. Recurrent corneal erosions, not that we commonly see, but whenever we do, sometimes these can be challenging to handle. Quick question for you. Most of the times with bandage, contact lens, and lubrication, recurrent corneal erosions probably would resolve. Not very often would we have to progress on to anterior stromal puncture or YAG or PTK. In your experience, how frequently have you needed to go on to PTK or YAG?
actually my threshold to do PTK is very low. I feel if the patient can afford it, I don't really wait for medical management also in many of the cases, because you have this long-standing history and they've suffered for long enough. And you, especially the macro erosions, if you're seeing, you know that they won't really heal very well most of the time. So if it's one of those micro erosions that you cannot really see on the slit lamp, yes, using a bandage contact lens works. But if it's macro erosions, the organizers, then I will not hesitate to do a PTK because it's quite harmless, and 10 to 15 microns of ablation doesn't really cause much of hyperopic shift in my experience. So my threshold to do PTK is not very high, not very low. Only if the patient cannot afford, I will go for other options like alcohol delamination or anti-stromal puncture. I have not tried YAG till now.
But YAG sounds fancy. I think hearing you, I probably was thinking that we should try YAG sometime, not just the anterior stromal puncture.
Yeah, even I want to try it, but I haven't tried it. Basically, don't get around to it. If the patient can afford it, I'll just do an exam of PTK.
So I do have a question for Dr. Rishi and also the other panelists. Please feel free to join in the discussion. Dr. Himanshu, Dr. Kamran, Aditya. Question to you, Dr. Rishi, was: have you seen any difference in the outcomes or the success rates of, let's say, debridement with burr, polishing, and PTK when you have different various etiologies, like was a traumatic recurrent corneal erosion versus, let's say, something due to a stromal dystrophy. That is one, and also whether it's a more generalized one versus a very localized area of erosion.
So I don't like burr at all actually, because it's very uncontrolled. You can end up removing a little bit of stroma, and that can have a refractive effect. Second thing is, at the edge of the place where you're applying the burr, you are causing trauma to the epithelium again, and that also can cause erosion if it's a patient who has some sort of an underlying pathology, which is do an alcohol delamination if I have to, or
I think we lost the audio from Dr. Rishi. But Dr.
Okay. Am I audible now?
Yeah.
Yeah, basically what I was saying is I don't like to use the burr because it can remove a little bit of stroma, and that can cause some refractive. You'd rather just either puncture it or remove it with alcohol.
But do you see any difference in the outcomes when you just decide to puncture or do an alcohol delamination versus PTK in terms of traumatic versus traumatic erosions versus due to dystrophy?
Anterior stromal puncture, sometimes they can still have symptoms because in between the areas where you're punctured, they can still have micro erosions, which can make the patient symptomatic sometimes. So then you have to repeat it, or you may have to do 2 sittings or 3 sittings. So PTK is more definitive in my opinion. You do it once and it's done. The reason I don't really like to use alcohol delamination as the first choice is at the edge of
We lost the audio line from Dr. Rishi.
You'll have these tags at the edge, and I've had it. Remove the epithelium at the edges. Sometimes you can have small tags which can cause erosions again. So that's the reason I prefer PTK.
Dr. Himanshu, your opinion about this?
I would take it in a little different way, especially with OCT, anterior segment OCT in place. I would like to see, like Rishi showed some beautiful pictures of OCT. So I would like to evaluate the depth of abnormality. Sometimes these erosion can be related to relatively deeper localized abnormality, which cannot be treated by a PTK because they're much deeper, they are much excavated, and that kind of thing, which usually is traumatic, related to little sharper things or any other substance like that. Such kind of cases, as Abhishek, you were pointing out, a localized area of resurfacing with anything like burr may help. But remember, there our idea is not to resurface the basement membrane, that the area around that, and create a relatively obtuse angle so that the epithelium heals there. It may cause a little scarring there, but it will sort of not give up or give away later on. If it is related to the basement membrane, of course, doing anything like this thing would be much more disastrous because you are damaging it much more by using a burr. And as Rishi was pointing out, it can be totally uncontrolled. There, the PTK would surely be a generalized area involvement. PTK would surely be much better off. Anything where you feel that it's something which is possibly going to come back, the PTK is much more gentle than the other thing. Any anterior stromal puncture and those things away from the visual axis, where it's not going to affect the vision, I don't mind doing that if it's too recurrent and if we are not able to do that. Having said that, many times these things can recur at long term also. So also along with this thing, we need to treat surface abnormality like say dry eye or nocturnal leg of ophthalmos or infrequent blink and those things, and that may help us at the long run.
Thank you, Dr. Rishi. And I think we'll move on. Sahil, you wish to introduce the speaker?
So next we have Dr. Cameron Diaz. He is working currently at Oklahoma Health Center. He's fellowship in cornea. He this year received American Academy Award, but more importantly, he has been the best teacher, and he's received Best Teacher Award multiple times in last few years. So over to you, Dr. Cameron. Mitomycin C induced embolization of corneal vascularization.
Good morning, good afternoon, good evening, maybe good night to some of my colleagues across the world. Thank you so much for having me to join this Pan Ophthalmologica meeting. It's a privilege and an honor to be with you here today, and I'm very excited to talk about a topic which has been a lot of interest on listservs and some very limited publications, but I'm going to talk about MICE, which stands for mitomycin intravascular chemoembolization therapy as a primary and precursor treatment for corneal neovascularization. So let's move forward here. Those are my financial disclosures. So corneal neovascularization, as we know, is a major cause of corneal blindness, which itself is a leading cause of worldwide blindness. 1.4 million patients in 1995, and this number is very likely increasing. We see corneal neovascularization, or KNV, as a pathologic response to a variety of conditions, most predominantly infection, but other causes such as trauma, ischemia, non-infectious degenerations. And we see a table there on the right side, which gives a list of various different reasons for which we can see KNV. Vision loss in these conditions occurs for a variety of reasons, including lipid deposition and scarring, irregular astigmatism, loss of corneal clarity. And one of the things which is becoming increasingly recognized as a concurrent and perhaps an independent component of vision loss is many patients with KNV end up also having neurotrophic corneal disease, which, as we know, is very challenging depending on the severity of that etiology. In the past, we had a variety of strategies such as steroids, vasodestructive treatments like laser, PDT. There's been a lot of interest in fine needle diathermy, suture ligation, and what we've seen is that basically there's some inconsistent long-term success, though some authors like Harminder Dua have reported very good outcome rates. So this is still a viable therapy for some of these KNV types of cases. Obviously, a lot of interest in anti-VEGF, and I'm going to talk a little bit about why anti-VEGF may or may not work, but we've seen very high recurrence rates in the literature. And some authors have actually talked about using corneal cross-linking, especially as a precursor therapy for PKP. When we move on to the topic of PKP, we know, those of us who are experienced corneal surgeons, there's a very high risk of failure in vascularized corneas. The surgeries themselves can be very bloody, very messy, very challenging, but more importantly, even after surgery and you're patting yourself on the back for a job well done, very likely these grafts will fail despite best efforts with steroids and immunomodulator therapy. Well, why do these therapies fail? We know that within 2 weeks of corneal neovascularization, the majority of the vessels are covered by pericytes. So this is a topic we all learned way back in medical school, but pericytes are these cells which surround vessels which block the KNV. It kind of envision like a blanket or a shield that prevents some of the medications that we use from affecting the vessels. But more importantly, the pericytes are not dependent on VEGF for survival. This is one of the reasons why anti-VEGF therapies often fail. So therefore, therapeutic strategies that we use, especially with anti-VEGF, are most effective if applied very early in the disease course, but very often these patients present very late, and that's why we see a failure or limited success of anti-VEGF therapy. So this is, again, just a picture showing why anti-VEGF therapies don't work. The problem is the pericytes, which form this barrier or shield around the vessels of interest. So it's really time to think outside the box and see what else we can do for these very challenging situations. So the concept of intravascular chemoembolization, what the heck is that? Well, the idea of using pharmaceutical agents to destroy blood vessels. This has been used for various liver cancers and vascular types of pathologies. So the idea is, can we use mitomycin C? As we know, we use mitomycin C in ophthalmology and glaucoma and corneal refractive surgery. After PTK, for example, I like using that in the beautiful presentation that came after me. I love using mitomycin C in those cases. But the idea is, can we use mitomycin C to destroy this annoying, pesky, unwanted KNV, which plagues many of us cornea specialists. So mitomycin Z embolization may be very effective because it halts and destroys the existing blood vessels, and more importantly, prevents new KNV from forming. So in other words, we have irreversible damage that can be caused by mitomycin C. We know that from other specialties outside of ophthalmology that mitomycin C has damage to endothelial cells, and basically that it's irreversible damage on the cellular level of vascular endothelium. So this idea of using mice really has to be, the credit has to be given to Dean Owano, who's from North Carolina, someone I view as a colleague and an elder mentor figure. But Dean's idea was to use mitomycin C to chemoembolize these vessels, and they published a paper in 2021 there reporting the short-term results of 3 patients with lipid keratopathy who had failed conventional therapy, and all of them underwent mice, and all 3 patients achieved resolution of KNV, absorption of the lipid keratopathy without complications or loss of best-corrected visual acuity. So I want to talk a little bit about who's an ideal candidate for mice before showing some case examples from my practice. So the ideal candidate really is somebody with lipid keratopathy secondary to corneal neovascularization, which is threatening the central visual axis. Once the visual axis is involved, prognosis is less favorable, but I'll talk towards the end about using mice as a precursor therapy to then set yourself up for a favorable environment for corneal transplantation. Making sure the underlying cause is controlled, like HSV and lid margin disease, the eye is quiet and inflamed, and really you want to make sure the patient has failed conventional therapy so that you can approach the patient with this modality. So on the left here, we have an example of where mice would not be a good therapy. So we see a lot of vessels that are very fine, and I call these wispy and wimpy KNV types of vessels that you'll see here in a case looks like a graft rejection in a PKP. Whereas on the right side, we see a good candidate. We want to look for kind of like this engorged, beefy, juicy vessels that are just a few vessels rather than this fine, lacy network of vessels. So on the left side, this is not a good candidate. Whereas on the right side, this would be a good candidate because we can almost see that right here would be a great place to go ahead and inject the mitomycin C. Preoperative planning, getting slit lamp photos, anterior segment OCT. I like photos because it helps the patient also to see the wow before and after effects. And very importantly, like I said, checking the corneal sensation with an anesthesiometer. As I mentioned, that many of these patients have concurrent neurotrophic disease that we often fail to appreciate until very later in the course. So the protocol is to use a very thin gauge, a 33 gauge or 34 gauge needle, making sure that it's a luer slip and a luer lock. A 30 gauge or even a 32 gauge is going to be too big. We want to use mitomycin C at that concentration about 0.3 to 0.4, injecting at 0.01 to 0.05 ml. So notice that this is very low doses. The max we're going to inject is about 0.02 milligrams so that, to alleviate any safety concerns. Aim for the largest vessel inside the limbus, and you really have to inject with some force and hold it. It can't be sort of a very delicate force because remember, we're cannulating a very small vessel and we're wanting that mitomycin C to kind of get through. Look for a flash once inside the vessel, and we want to look for blanching, understanding that some patients may require repeat treatments. This is a picture here at the top. This is the luer slip that we want. We do not want to use a luer lock needle that we see down below. This is one of the first procedures videotaped. This is actually Dean's procedure. He was very kind to share this with me. So we can see that he's cannulating the vessel, getting that flash and injecting the mitomycin C, and we're slowing that down here, showing that hit. And we'll see the vessels kind of blanching as he kind of gets inside the vessel in order to deliver the mitomycin C here. This should play in just a second here. It should be playing. And we can see when this is slowed down, when the mitomycin C is injected with some force, that should be able to see the blanching that happens when that gets in there. And just another, there we see the blanching, and we see the whitening happening there of those vessels over here. So again, another intravascular hit where the vessel is kind of being cannulated and the injection is being done, and we're going to get the blanching that happens very shortly as there we go, we're getting the blanching there. So that's kind of what that looks like there. Again, you want to aim for right inside the vessel and try to cannulate, look at that flash. Here's one of my videos of thing. I'll speed it up here a little bit. Again, we're looking for that flash and then injecting. And notice as we're injecting here, we're going to get some of those, we see the blanching of the vessels there. Where you see the blanching of the vessels there, that's happening, that's a hit. And then this patient actually had it on the other side. So I'm going to show going to the other side there, just jump ahead for the sake of time. And I'm going to go back here and notice right at injecting, you see that crystalline formation. That's a good sign that there's blanching in the areas of the vessels that we want there. So that's the procedure. I like to do this in the operating room. Obviously the optics of the slit lamp are better, but I just worry about the mitomycin C toxicity, and you can rinse that off the surface. So that's what that looks like at the end of the case. So it may not look very impressive, but these patients have a very impressive response afterwards. So those are some videos of what the procedure looks like. It's very common in the first week or so to kind of see this hemorrhage and lipid accumulating in the cornea. This is the so-called pizza pie sign. So it looks like a pizza pie in the cornea. This is blood and lipid that's trapped in the corneal stroma. Not to be panicked when we see this. Understanding that is going to take some time for this to absorb over the next several months. We can see here ANSEC OCT showing a stromal compaction, which can cause some induced astigmatism in patients afterwards. So here are some cases here. This is a patient, she's the mother of an optometrist, and we see this vessel that's kind of coming towards the visual axis here. It's starting to leak lipid here. So I did mice on her. Here's 1 week later, we see the hemorrhage here in the subconj area space, but we can already see this vessel starting to regress after 1 week. And here she is 3 months later, the vessel's completely gone. We still have a little bit of the residual scarring here, but the vision has improved to 20/25. She has a little early cataract here, but we were able to avoid this vessel kind of creeping into the visual axis here. So here's another case of mice where mice was done in this patient here, May of 2021. We can see these three large beefy vessels there, and the vision was 125. We did mice in May of 2021, and we can see here about 1 month later that there's a significant regression of the vessels. There's obviously still going to be some lipid scarring and deposition there, but the vision has improved to 20/40. And 6 months later here, more absorption of the scarring. Obviously, we still have some occupying of the visual axis, but basically this patient was 20/40 and chose not to pursue any further therapy like that. So we're able to avoid corneal transplantation in this patient. Here's another case. This is actually one of Dean's cases here. We can see the irregular astigmatism that's induced by the vessels there. And 6 months later, we can see regression of the vessels maintained 1 year later. Again, you can still see some scarring there that still remains, but much better here when we look at the before mice pictures and post mice pictures, and we can see the improvement of the astigmatism, which is a little bit more regular now post mice compared to what we saw pre-mice. Here's another patient of mine. This is a patient who undergone corneal transplant years ago for HSV, had a recurrence, and we had some vessels that were crossing the graft-host junction. This is April of 2022. And I decided to watch it. I said, she was 20/40, let's leave it alone. And then January of this year, I see more lipid deposition and kind of getting a partial light blocking effect. So I went ahead and did mice in February of earlier this year. And here are the results when I just saw her a couple of weeks ago. We can see that these vessels have completely regressed. We still have some of the scarring, but the visual acuity has improved to 20/30, and we don't have to do any type of surgery for this patient here. So this is a great way that we were able to avoid a graft failure and improve the vision. And this is a young lady, she's only 34 years old and is able to continue wearing her glasses and contact lenses. I want to shift gears here to mice as a precursor therapy where it can kind of set us up for surgeries down the road. Here's a patient that came to see me in February of 2021. Visual acuity was 20/30 at that time. And at that time, I did give some subconch Kenalog, and I gave some Avastin there right near the vessels, and it didn't really improve a whole lot. And then this patient disappeared for about 10, 11 months and comes to see us in January of 2022. And we can see a huge amount of corneal vessels, lipid scarring occupying the visual axis. And you can see this is the same patient by this iris nevus here. So I'm not suddenly changing and showing you a new different patient. So this patient's vision had obviously decreased significantly to 20/400. So I decided to go ahead and do mice on this patient, February 2022. Again, we see the pizza pie cornea. This is the first day after the surgery. By May, he's looking a little bit better in terms of regression of the vessels, but the visual acuity is still 20/200. So I waited for a while, and then basically in July of 2022, did penetrating keratoplasty for this patient. And I thought that this was a good strategy, because if we tried to do the PKP with all that K and V, the surgery would not have been pleasant, and the graft would likely not have survived. His visual acuity this time improved to about 20/40. And then earlier this year, this cataract got worse. So I did cataract surgery, and here he is now in March of 2023. We cut some of these sutures at the time of cataract surgery, and he sees 20/30 with glasses. So we're able to kind of, and so he's now more than a year out without corneal rejection and has maintained his 20/30 vision. Here's another case of precursor therapy. So this is a patient, visual acuity 20/100, sort of has this double barrel vessels here encroaching on the visual axis. Visual acuity is 2100. So April of 2023, I went ahead and did mice. So here are all the preoperative pictures. And then 1 week later, again, that pizza pie cornea, the blood and lipid that's trapped there. So again, not to be panicky, if you see this picture, 1 month later, we start seeing some resolution. 2 months later, more and more resolution. And basically what I did was I waited till August, did cataract surgery in this eye. And here are on the top right, here are both slit and sclerotic scatter views here. So we can still see we have some lipid and scarring in the visual axis, but the vessels have more or less regressed. There is some regression, I will admit, right down here, but we're watching it. And I've actually started this patient on topical losartan for about 2 weeks to see whether or not this will kind of thin out the scarring. And this is based on this paper, which was in JRS with Ambrosio, talking about some success in rabbit models and things like that. So I figured, why not try that before jumping to do any type of corneal surgery. I'll end with a limited success case. This is one of my early cases, so I don't want to just paint this picture that everything is perfect with mice, but this is one of my early cases, April 2022. And I can, in retrospect, I know that this was a bad case to choose, because we can see that this is a very fine, lacy network of vessels. We don't have that beefy, juicy vessel like we saw in some of the previous cases. I went ahead and did mice, again, blood and thunder, pizza pie fundus kind of appearance there. And basically what ends up happening is a year later, we see the corneal neovascularization has regressed, but there's significant scarring. This patient does have neurotrophic corneal disease as well, and the vision is still very limited at 20/100, and so we're just conservatively managing it. She does not want to undergo any penetrating keratoplasty at this time. Has a lot of comorbidities as well. So I wanted to share this last case just to show that, hey, not everything is rosy and perfect with mice, but sometimes you have to really pick the right patient in order to have success. So my final thoughts is corneal neovascularization is a very challenging problem to manage. Early diagnosis with early modalities can have some partial and limited success, but as we know that many times this recurs. Mice is a newly introduced procedure for KNV, which previously lacks any good treatment options. And I would propose to my colleagues and the audience that we can consider mice as both a primary or precursor procedure, though some patients may require multiple and/or alternative therapies. So thank you for your kind attention, and I'm happy to entertain any questions or comments at this time. Thank you.
Wonderful technique, doctor. Just a quick question. We have been using fine needle diathermy with reasonable results. One, first is what additional advantages does it offer? And two, have you ever have mitomycin-induced endothelial damage or any toxic effects of mitomycin?
Yeah, no, great point. As I mentioned, fine needle diathermy has been a tried and true approach. As I mentioned, Harminder Dua's group has published quite a bit about it, and it's very popular, and it's very low cost technique, which works well. So I don't think that there's anything wrong with fine needle diathermy per se. As far as we have not seen any endothelial damage, we are following these patients with specular microscopies and checking their pachymetry. Obviously, we have only about a year and a half data of doing this, but thankfully, I've done about 16 or 17 cases in this time, and also looking with Dean Owano's cases, and we're trying to compile cases from colleagues across the world. So if anybody wants to contribute, please contact me. But we've not seen any endothelial decompensation where patients have required EK or keratoplasty type of interventions. But I do agree that that is something that we have to be very mindful for. But I think if we're injecting in very low concentrations, rinsing it off the surface of the eye, and that's why doing it in the operating room is a very important component of it, I think it can be safely done. But obviously, we need long-term follow-up before we can kind of make these definitive statements.
So I have a question for Dr. Kamran as well. First of all, excellent, and it was a very novel technique, definitely something new which I learned today. But my question is that, so most of your cases which you showed here, the neovascularization seemed to be probably 1 or 2 clock hours and not more than that. So is there a threshold beyond which you would not go in terms of clock hours? And secondly, Sahil talked about the adverse effects on the endothelium, but have you seen any adverse effects on the adjoining limbal architecture on the limbal stems?
Yeah, excellent question. So I think obviously this works well for sectoral neovascularization. So if you have like a rosacea blepharitis type of a neovascularization or corneal pannus or limbal stem cell, kind of more than, I would say, 4 to 5 clock hours, then you may not want to do, because there's too many vessels to then try to have to cannulate, and too much mitomycin that can kind of get in, either damage the endothelium or potentially damage the limbal niche or the limbal stem cells around the cornea. So I think this works best in cases for 3 to 4 clock hours of sectoral wedge-shaped neovascularization that is threatening the visual axis. And that's what really allows you to kind of cannulate those beefy vessels. But we have not seen any limbal stem cell deficiency that is formed in these cases, but obviously we need more data and longer term follow-up to be able to say that with more confidence. So I think we're still very much in the early days of this therapy. It's a very exciting therapy, but obviously we will need to follow these patients for a long term to ascertain that this is a viable therapy for the future.
And one last question about the procedure. Have you ever had to repeat an injection, or and if so, how long would you wait to do so?
Great question. So I personally have not, but I have talked to colleagues who've done, repeat therapies, 2 or even 3 times. I think the minimum course is really to make sure that there's quiescence. It's not getting a whole lot worse. So I would wait at least 3 to 4 months if I saw recurrence in my hands to inject. But all of the cases that I have done, fortunately, I have not had to re-inject, though I did share that one case of the cataract surgery patient, which it was starting to regress a little bit inferiorly there, or return inferiorly there. I'm just watching it for now. I don't think I'm going to inject unless it gets a whole lot worse. But I think those who have injected or repeat injected have waited about 3 to 4 months before doing repeat treatments.
Thank you, Dr. Kamran. And it was indeed a very well conducted talk. And really, like I said, it was something really novel which I learned today. And our next speaker today is Dr. Himanshu Matalia, who again in circles of corneal surgeons needs no introduction. And if you are a corneal surgeon practicing in India and you don't know him, then I would say, what are you doing? Because he's the immediate past president of Corneal Society of India, and is also a very senior corneal surgeon who's practicing at Narayan Nethralaya in Bangalore. And he'll be talking to us about visual rehabilitation in keratoconus. Over to you, Dr. Himanshu.
Thank you, Abhishek. And can you see my slides?
Yes, we can see your slides. We can also hear you.
Okay, perfect. At the outset, I would like to thank my friends out here, Vaibhav, Abhishek, Sahil, and many of you. to spend time with you, evening with you itself is such wonderful. And to be part of such kind of a pan-ophthalmic webinar is certainly an honor. So I'm going to talk to you about visual rehabilitation in keratoconus. I do not have any financial interest here. When we talk about keratoconus, I would like to distribute the keratoconus into central cone, whether it's decentered cone, whether it's progressing, not progressing, and whether it's advanced keratoconus. Whatever we do, we know that keratoconus treatment is important, that we stop the progression, but final goal has to be visual rehabilitation. Without visual rehabilitation, treatment is never complete. So whenever we do any other treatment or any part of the treatment of keratoconus, it's very important to remember that's not the end. It may be the beginning. So we do cross-linking, that's stabilization of the cone, but we have to have plan of visual rehabilitation. And without that, the treatment is never complete. So visual rehabilitation may be a very large topic, but there are a few important parts of visual rehabilitation which are cornerstone of the treatment of keratoconus. One of the most important thing and one of the best thing for the visual rehabilitation is contact lens. With the advancement of contact lenses, there are so many contact lenses which are out there. But with the advent of scleral and miniscleral lenses, the change of visual rehabilitation with keratoconus has totally changed. And these ectatic cases, especially advanced ectasia, where you can fit the contact lens, you can delay the corneal transplant. So where do they fit into my cases? Well, I offer them for the best visual rehabilitation after collagen cross-linking. If I'm able to fit the contact lens in cross-linking cases, I would offer them there. If the case is very advanced and I'm not able to do cross-linking, but I need to do corneal transplantation, and the contact lens can delay the corneal transplantation, I would surely like to offer them. It also has a role in case where post-PKP astigmatism or abnormality is there. So going by the case, one young girl who has been referred for the keratoconus has the corneal thickness, which is the stromal thickness, mind you, is very low, and there is significant epithelial hypertrophy here. Mind you, whenever you see significant Vogt-Stry in the visual axis area, please do an anterior segment OCT, and you might be surprised in some cases where you have significant epithelial hypertrophy. Such kind of cases are not best cases or suitable for regular collagen cross-linking. But you still can visually rehabilitate them by using these newer contact lenses like scleral lenses, here the miniscleral lenses, which can give them significant vision. So I would like to evaluate all our treatment option today based on effectiveness of treatment, technical complexity, other usage, and the value for money. So if we put our contact lens here, well, they are effective, extremely effective. Technical complexity, some of these lenses may not be very easy to dispense, and you may need some expertise, but of course, it's not difficult. Other uses, of course, we can use them in any other field of cornea, and they are certainly value for money. So I would definitely say I would keep it in my armamentarium. So what do we learn from here? That newer contact lens can be fitted in advanced cones too. The best visual rehabilitation you have achieved is with the hard contact lens, which you can fit there. And very advanced cone, please do a pentacam along with ASOCT. ASOCT along with the pentacam, they may be more reliable there. Coming to the next mode of visual rehabilitation, intracorneal ring implants. There are quite a few out there, but my experience is with intact, so I would stick to intact. Now, where does it fit into our goal? Well, where there is a central cone, which is low spherical equivalent, you can combine intracorneal ring implants with cross-linking. Or if it's a decentered cone, you can put either single ring or asymmetric ring implantation. Where does it fit in? Why do we need intracorneal ring implants? Well, it's a very simple treatment nowadays, especially with femtosecond laser in place. Creating channel is not a big deal at all. And inserting a ring implant into the stroma is as simple as it takes. And what it does is it localizes the cone, it flattens the cone, and then it makes the surface much more regular. And doing this thing, possibly you can visually rehabilitate patient by just dispensing glasses or contact lens sometime. Regular contact lens may work, and you may not need even hard lens. But if I have to use these intracorneal ring implants at one place, that would be the post-LASIK ectasia. Let me prove it with one such presentation. One young lady who had post-LASIK ectasia, and as you can see from the picture here, she has significant inferior ectasia. Now, if you see the upper part does show now still pre-existing flattening because of the LASIK, and that's the case in most of these cases. So the problem is more in localized area, and if you want to flatten that area by inserting a ring, it actually makes the surface much more regular, and it makes the surface as if there was LASIK done, and the visual rehabilitation is much more effective in these cases. So what it does, it gives you a much faster visual rehabilitation and much more regular rehabilitation. Again, if we evaluate based on our method effectiveness of treatment for moderate to mild cone, it's certainly effective, not very effective in advanced cone. Technically, it is simple, but you may need little planning expertise there, which though is a little tricky, but may not always be predictable. Other use, of course, other than ectasia and keratoconus and PMD, it does not have much role. Value for money, it is cost. It's a cost which can be the limiting factor here. If you have femtosecond laser, it partly reduces the cost for you as a surgeon, but for the patient, it certainly incurs significant cost. So what do we gather from here? Well, the intracorneal ring implants improves quality of vision, works well for mild to moderate keratoconus, especially low spherical equivalent, and best for post-LASIK ectasia. Use if you have already femtosecond laser, and certainly these cases are worth trying out. The next form of visual rehabilitation can be phakic IOL or even the intraocular lenses along with the cataract surgery. Coming to the phakic IOL, where does it fit into this thing? Well, central cone. Again, when the cross-linking has stabilized the cone or it's already stabilized and there is no progression, the cross-linking has stabilized the surface for at least 6 to 9 months. So we know that a progressive changes have not occurred. And beyond that, if the phakic IOL is suitable there, we surely can consider. We have to remember that phakic, not every case of keratoconus is suitable phakic IOL. There should be a good potential vision. There is no scarring in the center. And if there is associated with spherical error like high myopia, it works wonderfully well here. Let me again take you through a case here. A young male who had undergone cross-linking, stabilized cone for a couple of years' time now. And if you look at the vision, the refractive error shows significant high spherical as well as significantly high cylindrical error here. Central cone and anterior chamber depth deep enough, and we took up this case for phakic IOL here. Such kind of cases, remember, whenever you're operating, there may be little disturbance on your visualization of your phakic IOL while inserting because of the ring, but all you need to do is just move the eyeball on side to side and they should be fine. The surgery is not so different from any other regular phakic IOL implantation, so I don't think I'm going to spend more time here. But what it does is it does give you a significant reduction in your spherocylindrical power. Remember, any higher order aberration like comma or spherical aberration may not be corrected here, or rather would not be corrected here. So patient may have some glare issue or ghosting issue, but reducing spherocylinder from a large amount can certainly give them very good day-to-day activity and visual outcome. So if you can see from here, pre-op significant abnormality to post-op quite significantly decent quality of vision does improve the quality of life of the patient. So where do we fit that in our system? Well, is it effective? In selected cases, it certainly is effective. Remember, sizing can be an issue because you're looking at the central anterior chamber depth, which can be deep enough because of the cone, but the peripheral depth may not be as good. So be aware of the configuration of iris and just look at the case in toto rather than central AC depth only. Technical complexity, if we know that it's a very simple procedure and is performed by most of us very regularly, so it's not a different procedure for keratoconus. It is used in cases like myopia and hyperopia. So it's not specialized, specially reserved for keratoconus. So yes, it does have other role. Value for money, it does not require any extra infrastructure or instrument. So of course, value for money. So where do we fit in? Phakic IOL, best reserved for central cone, especially with the high spherical equivalent. Beware if topo and, or rather I would say intuitive topo axis and reflection are way away from each other, just be aware and just be do not venture in these cases. Central anterior chamber depth can be sometimes misleading. Cases which are older cases where they have limited visualization because of the cataract, we can also do cataract surgery with the intraocular lens implantation. So let me again take you through a case where you have a significant high myopia with keratoconus here, and the axial length is again extremely high. So the person had high myopia, keratoconus, and had significant toricity there. So we decided we had to rather plan a cataract surgery. Now, customization was required here, and mind you, there was a toricity involved here. So here the customization was not related to the toricity, but it was related to the sphericity here. So spherical power here was in myopia, and we needed cylindrical power also. So we did a customized toric IOL here. And patient had a decent visual outcome here, as you can see from the quality of vision as well as the post-op outcome. That patient was very happy, and patient did significantly well. So where do we fit toric IOLs in keratoconus cases? Well, where we have relatively central cone, where manifest axis and topo axis are very similar, especially pre-cataract data when you have. If the cone is not very central, you would rather do intracorneal ring implantation or use your laser, topo-guided laser to regularize the surface and then possibly offer a customized toric or toric intraocular lenses in these cases. Regular cases may not be the best cases for the toric IOL. So what is the effectiveness of the treatment? It's best reserved for regular and central cone and use full and limited cases. Not every cases you should do a toric IOL. Technically, they're not so difficult, but if it is a complex case, you may need a little more experience to decide about that. It is useful for toric IOLs are used in all our cataract surgery. It's not a big deal. Value for money, of course, if there are indicated cases, we don't need anything special out there. So we certainly can use. So what do we learn from here? Toric IOL are best reserved for central cone. Topo and refractive axis are matching. They are the best cases, and they are usually reserved for selected cases. The final part is topo-guided PRK or topo-guided partial PRK. Where does it fit? Well, the cone is either centered with a decent corneal thickness or cone is decentered with a decent corneal thickness available in our hand. We can do these kind of modalities. Irregular cornea, we try to get a topogalizer image and connect it to our laser platform and then ablate the irregularity and aim for the regularization of the surface. If the cornea is relatively regular, where we may be able to treat a significant amount of sphere and cylinder there, and well, that can have a relatively good refractive outcome also. But if the cone is decentered or irregular surface, well, we would like to achieve a relatively regular surface so that we can either visually rehabilitate with spherocylinder glasses or even the soft contact lens also. going by case. Let's take this case, a young male who has come to us. And if you talk about the left eye, relatively centered con, but still inferior paracentral area, which is steeper. If you see here, this is the pre-op sagittal topography. That's how it looks like, an asymmetric curvature here. Post-operatively, we can make it much more symmetric, and this person was very, very happy with that simple soft toric contact lens. And so what it does is, even if it's a surface which is relatively irregular, we can possibly regularize the surface along with collagen cross-linking. Remember, this is visual rehabilitation. The stoppage of the cross keratoconus has to be the cross-linking. What it does is, it actually reduces the irregularity and then possibly helps us to improve the quality of vision. Where does it fit? Well, it's effective in selected cases, useful especially when you have good pachymetry values. If you do not have good pachymetry, of course, not a case to offer. Technically, it may require a little bit of understanding of your topo-guided treatment or your platform. The planning requires a little understanding there, but it's still simple. The surgery is very simple. Of course, the platform, your laser platform, is used for your refractive regular cases. Is it value for money? Well, if you have a LASIK machine and if you can do topo-guided treatment, this is certainly one treatment where you would want to use for your keratoconus cases. So where do we use that? Well, the good pachymetry, more than 450 micron, where you are able to get repeatable and reliable topography or your machine fluid imaging. Maximum ablation, you would want 50 to 16 micron. You would like to address cylinder more than the sphere. Main goal is to regularize the surface. In advanced cones where we can't do any of these things, we may have to resort to corneal transplantation. With the femtosecond laser and all these things, there are many ways where we have our options opened up. We can do a customized keratoplasty by using shaped corneal transplants like femtosecond laser. You can do full thickness there, or you can do a DALK with there. Here I'm showing the case of femto mushroom DALK, where I'm using big bubble technique and bearing the Descemet membrane there to perform the DALK. The procedure is not so different, so I don't think I would rather waste your time there. By delaminizing the Descemet membrane, what we are doing here is creating a graphose junction, which is relatively regular with the shape of mushroom there, and gives us much better outcome in the curvature, or rather, I would say topographically. Where do we fit here? Well, effectively, it's a very good case in advanced cone. It's useful if you're talking about a shaped corneal transplant, useful in good pachymetry area, but a normal DALK is absolutely useful for most of the cases. Technically, it is a case, it is a technique which needs to be learned. There is a little learning curve out there, but as a corneal surgeon, this is certainly not difficult thing for us. Many other cases we can use them, and it's value for money. Of course, it's value for money, and we all should be doing that. So where do we do best use for advanced cases and has a little learning curve, but for a trained corneal surgeon, we should be offering it. So how do we treat our keratoconus? Divide them central cone, decentral cone. If they are progressing, stop the progression with the collagen cross-linking and visual rehabilitation based on the technique, whatever we feel best suited for the care. Thank you very much.
Thank you, Dr. Himanshu. That was indeed a comprehensive recapitulation of all the possible modalities along with their indications and contraindications, pitfalls. And I would like to point out here that this algorithm which Dr. Himanshu just mentioned has been very nicely captured in a paper from Narayan Nethralaya. So anybody who wishes to go back can certainly do a literature search and go back and read it up. Just one question, Dr. Himanshu, in interest of time, not at all related to what you have already presented, but something which you have not. Probably, I just want to your opinion. Do you have any experience with the newer modality being introduced, which is CARES, that is corneal allogenic intrastomal ring segment, and what is your experience with it?
So Abhishek, I personally don't have experience with CARES, but I certainly would say it's definitely worth trying out modality. The advantage being a tissue which is biocompatible tissue, hence something like a plastic which we are inserting into cornea, which can lead to slow atrophy of anterior stroma and which can many times lead to extrusion of the ring. We surely can prevent that. Having said that, still, when manually inserting these things can be a little bit tricky. So a use of femtosecond laser to create the channel and then putting these segments, it's certainly worth it. In spite of whatever we do, remember one thing, that the visual outcome of any of these cases cannot be predicted. So these are not cases where you can predict the outcome by saying that, you know what, I will make your cornea so regular that your vision can improve. So it's not predictability, which is something which I would wish there was that. But the advantage on top of it is that if we are able to insert this thing a little deeper and later on follow it up with a topo-guided treatment, well, possibly we can have a little better outcome. So it's very exciting, and I mean, I'm sure in coming days we would definitely love to try it out.
Yeah, I totally agree with you, Dr. Himanshu, that it's a wonderful and exciting prospect. Only time will tell about the long-term outcomes and the efficacy of the procedure. I see Dr. Praveen has also joined us. So, Dr. Praveen, if you are here, your opinion about CARES, if you have tried some cases.
Hey, hi Abhishek, hi everyone, hi Himanshu. I have not tried CARES, so I wouldn't be able to give an opinion. And I'm also not a big fan of intacts or interstomal rings like Himanshu just mentioned. I mean, if you are doing surgery for keratoconus and if you want to be able to tell the patient what to expect, you want some amount of refractive protection. Unfortunately, don't see that very much with interstomal rings. And with the excellent outcomes that we have right now with cross-linking and add-on procedures, I think those are more done commonly. And also, if more severe cases, I think we prefer to do DALC. And I'm pretty aggressive in advising DALC for keratoconus. So not a big fan of either.
So I think both Dr. Himanshu and Dr. Praveen have touched upon an important point about counseling the patient and setting the patient expectations in keratoconus procedures and keratoconus treatment. And I think in the interest of time, we'll move ahead to the next presentation. The next presentation is by Dr. Aditya Pradhan. Dr. Aditya Pradhan is a consultant ophthalmologist and a corneal surgeon practicing in Disha Hospital. And he is a very well-read, well-spoken person and very up-to-date with all the literature. And he'll be talking to us about newer modalities in management of dry eye disease. Aditya, over to you. Aditya, if you are already speaking, you're not audible.
Yeah. Can you hear me now?
Yes.
Yeah. So thank you, Dr. Abhishek, for the kind intro. So I'll be talking on a topic which is controversial by default. As clinicians, we all come across patients having different degrees of severity of dry eye. So we all wish to know that what actually works in our hands in daily practice, what may or may not work. So I have no financial interest to disclose. So basically, DUCE 2 gave us 3 different categories of dry eye disease. One which was predominantly aqueous deficient. The other extreme was the evaporative dry eye, mostly due to MGD. And some patients which fall in between who share features of both the types, that is the mixed dry eye disease. So apart from a good clinical exam, we have different newer diagnostic devices on the block. This is from a recently published article which shows the different parameters which each machine can actually measure and analyze and give to you in a easy to read printout. But nothing beats a good clinical exam. So these are all just additional tools for easier visualization and better counseling of the patient. So the vicious cycle of inflammation is what we are targeting in the treatment of dry eye, and we have different products, so to say, available in the armamentarium, which target the different steps of the disease progression. Some target the tear film, some target the hyperosmolarity, some reduce the inflammation directly, some work indirectly. So out of these, which actually work, which actually don't work, let us see in the coming slides. So the Japanese are pretty fond of this tear film targeted therapy, in which, as we know, we have these 3 layers. So we have to analyze which layer is actually affected by a thorough clinical examination and staining of the ocular surface. And then we go back and see what agents are actually working on which layer. So if you analyze the patient carefully on the slit lamp, and you see there is a predominant aqueous deficiency, maybe artificial tears, and certain form of topical anti-inflammatory agents are the way to go. If you have more of the evaporative dry eye, apart from the artificial tears, we now have a product in the market which contains lipid supplement also, which is claimed to improve the signs and symptoms on the ocular surface. So if you see the aqueous deficiency dry eye, so you have 3 main agents at your disposal. One are the tear substitutes, the anti-inflammatories, and we have the secretagogues, which are both available in the topical and the oral formulation. So let us go to the artificial tear. So you have 3 types of artificial tears or tear substitutes. Some are basically very simple form is the wetting agents, which basically just lubricate the surface and stay for a very short time on the ocular surface. Then you have multiple action tear substitutes, which are a step above, and you have a single molecule or a combination of different molecules which improve the quality and the quantity of the tear film. And the more advanced one are the polymers, which are called as the ocular surface modulators. So they promote homeostasis and decrease the apoptosis, which is one of the causative agents in the vicious cycle of dry eye. So if you see this bottle of dry eye, what does it have? What makes up a bottle of a dry eye? Artificial tear substitute. So you have viscosity enhancing agents or demulcents or lubricants. Some of the drops do contain electrolytes, which are essential to the ocular surface. Some are having agents which promote the wound healing. Some which reduce the hyperosmolarity on the surface. And some have the lipid supplements, that is the oily agents or the surfactants. So if you see the systematic review published in January this year, so basically they reached, after reviewing around 50 or 60 different types of studies, they came to certain truths or observations. So basically, combination formulations, as we know from our innate clinical practice, are more effective than single active ingredient tears. And if you add trehalose to either hyaluronate or sodium hyaluronate, it benefits better. More complex the formulation, generally the trend is towards having a better effect on the ocular surface. Then polyethylene glycol is a favorable agent to have in your armamentarium. And normally hyaluronate is performing better than HPMC, but certain studies have shown it does perform inferior to CMC. And more than just what drop you choose, you need long-term compliance on the side of the patient as well as the doctor. And this is where the counseling part actually comes in. And it at least 1/3 of the patient, that is 33% of your clinical practice of those having dry ears, will not improve with just artificial tears alone. But that also, to predict that, you have to wait for a month of compliant use and then pronounce that this is something recalcitrant and needs something better than just artificial tears. So another question frequently asked, or which comes in our mind, is whether autologous serum eye drops, which is prepared from the patient's own blood, is it useful for dry eye? So basically, they studied 6 RCTs with 116 participants, and some of them have compared the serum with the artificial tears. So the conclusion was basically they were not very certain as regards to the benefit. There may be a very small subset of patients which may actually benefit from autologous serum eye drops, but it is something not which we would use as a first line or as the sole therapy. Do antibiotics work, especially in MGD and blepharitis? They do, but it is just a transient benefit, and sustained evidence that it improves over time or maintains the benefit is still lacking. And recent studies have shown that just a pulse dose of oral azithromycin is as good as a prolonged course of doxycycline with lesser side effects. So we need to reassess whether we actually need to continue a prolonged antibiotic treatment of the ocular surface. Also, since the long-term benefits are unclear and resistance is on the rise. There is topical chloroquine eye drops which are available in the market, and we have all seen the drops ourselves, but again there is no conclusive evidence that they do help, because the number of studies is few currently, and this randomized controlled trials are also lacking. And this meta-analysis of the published literature has shown that there is very doubtful benefit. So not again a recommended treatment in the management of dry eye. Vitamin D supplementation, mostly all of us, many of us in this fast-paced life are deficient in vitamin D due to low sunlight exposure. And on a macro level, it does regulate important parts of the inflammatory cycle. So yes, there may be a benefit overall by supplementation of vitamin D, but it is not the magic bullet that we were hoping for. Eyelid warming devices, they are available on online shopping portals. Many patients do come and show us photographs that whether they can use this at home. They're definitely useful and much better than the conventional warm compression lid massage, which we advise our patients, which is of dubious value simply because the compliance is poor and many patients do it in the wrong way. Either the timing is wrong, the temperature is wrong, the way of massaging and expressing the glands is wrong. So we just advise it and leave it. We don't know actually what the patient is up to. So some of these devices, which you may run from your laptop, just power it from your laptop, or you can use a power bank as well, which are working on USB-C, are definitely recommended and a convenient way to go about. So one of these, the warming device, it's not exactly a warming device, but which are heavily advertised, is the intense pulse light therapy, and something called as the vectored thermal pulsation, which targets the heat only to a specific part of the lid, upper lid and the lower lid, away from the cornea. And both of them are useful, but the LipiFlow, which is proprietary, is definitely higher in cost compared to the intense pulse light therapy. And both of these treatments, you have to repeat. The counseling has to be such that it is not a one-time application. You may need to repeat it at the end of 6 months or a year. So maybe once a year, so that the optimal results are maintained and the effect is for a longer lasting period. Another controversial, whether you should prescribe oral omega-3 fatty acids. So there was this DREAM study in 2018, which became a huge source of controversy, because then suddenly overnight everything was debunked, and then we were not sure whether we should continue writing these oral supplements. But current evidence suggests there is a benefit in the ocular quality of the ocular surface. And since omega-3 fatty acids, an uptick in their levels in the system is beneficial for the other parts of the body as well, especially the cardiovascular system. If the patients are already getting it prescribed for some other cause from some other specialty, there is no need to discontinue it. And in especially severe cases of MGD where you have exhausted all of your options, there is definitely one option you may try. Maybe it will benefit a certain subset of patients. In the pipeline, there are different drugs which are awaiting approval from the US FDA. So this is something called as the lotilaner ophthalmic solution. This is a drop-based therapy for the treatment of Demodex blepharitis. As we know that tea tree oil is currently the gold standard, but application of it is difficult. It is somewhat toxic if it is not used in the correct concentration, availability, dilution, everything is a problem. So this is a promising new drug in the pipeline. Then in something called as reproxalap, which is a RASP inhibitor. This is a non-steroidal agent which acts up very high up in the inflammatory cycle, and all without the side effects of steroids, but all the benefits of the steroids as well. Then you have something called as Novartis, which contains an omega-3 fatty acid ester as well. So this is supposedly it is a water-free eye drop, which is very new to me. And it combines the benefits of both the worlds and is supposedly in an advanced stage of clinical trials. And something which is in a code word, which is an ophthalmic keratolytic ointment for MGD. So this is basically an application, maybe not be used every time by the patient, maybe for OPD benefit whenever the patient visits you. So this is supposedly a keratolytic which opens up the blocked orifices of the meibomian glands and helps in easier expression of the blocked meibum secretion. So another future directions is basically the gut microbiota, which is implicated in a variety of diseases, right from ARMD to diabetic retinopathy and dry eye. So modulation of this may help in the improvement of dry eye. There is exciting therapies for lacrimal gland regeneration using stem cells, and also bioengineered lacrimal gland, somewhat of an artificial lacrimal gland, if you may. So in summary, what works on the left side is lifestyle modifications, which we need to stress enough. Sometimes we don't, we are lost in the burden of drops. Artificial tears, yes. Corticosteroids, immunosuppressants, including cyclosporine. Dicofosol is a secretagogue, which I discussed earlier. Sadly, it is not available in our country, but definitely on the rise in Japan and with good evidence in the literature. Lead warming, yes. Oral topical antibiotics, pulse therapy rather than a prolonged duration. Light therapy and vectored pulsation, yes, but again, repeated applications, it is costly. And scleral contact lenses are again underutilized, especially in the severe forms of Sjogren's syndrome. The right side may seem counterintuitive or controversial, but if you just go by the literature, there is not much of evidence. Either it is very borderline or shaky. So oral pilocarpine, cevimeline, we sometimes do prescribe, but again, it is not of sustained benefit. Punctal occlusion, we have all done it, we still do it, but there is not enough evidence in the literature that it is superior to the column on the left-hand side. Autologous serum of dubious benefit, not a first-line therapy, again, oral fatty acids. And vitamin D, as I said, maybe on for the entire system, but not specifically only for dry. So the take clinic message is basically spend more time in history and clinical examination rather than gadgets, and try and identify the type of dry eye and the layer involved. Before you decide on any surgery on the ocular surface, treat the dry eye first. Don't fix if the patient is happy with their drop, just let them continue it. And every patient and case is unique, so no formula is fitting everybody. But it's an expensive disease with expensive treatments, so always keep in mind the economic burden of it. Thank you so much.
Thank you, Aditya, for succinctly summarizing the various modalities available for dry eye treatment. I think you have rightly said that for many modalities, the jury is still out. Like, we do not yet know whether they really work or not. And one of the reasons probably is that the problem with the definition of dry eye, it keeps varying so much between the two studies that having a proper systematic review or a RCT or even a non-systematic review for these cases is pretty difficult. And but of course, there are always newer drugs on the horizon, which we need to see how do they work. So with that, we move to the last talk of today's session. And Sahil, go ahead, please.
It would be my pleasure to introduce Dr. PVK, Dr. Praveen Krishna, who has been a mentor and a teacher par excellence. His knowledge and his surgery skill set is both par excellence. With this, I would like to request Dr. Praveen Krishna to enlighten us about the transition from DSEC to DMEC.
Thanks, Sahil, if you can hear me all right. And also thank you, Abhishek, for having me on this session, as well as Vaibhav for thinking of me for Ophthalmologica, whatever it is. So, but following up on what Sahil said, I think in this screen are some of the people that I respect probably a lot, and also am extremely happy and proud of where they have reached. Sahil, Abhishek, Aditya, as well as Himanshu, my good friend. So I think I seldom will come across a panel or a group of people who I really like so much. So thank you for having me here. And since this is the last talk of the day, and also looks like the cricket match is very one-sided, Australia is in big trouble. What I'll try and do is I'll try and give you a little bit of perspective about a topic that I think is actually very close to my heart. And what I will do is speak to you about a little bit of the theory of transitioning from DSEC to DMAC. What is it that is important to know? And try and see if we can actually think about a little bit of the philosophy behind the transition as well. So to start with, let's just look at what are the important reasons why anybody should consider transitioning from a surgery like DSEC that is already working really well to a surgery like DMAC that has, in some people's minds, limited value. Well, there are several reasons why you could argue that you should transform from DSEC to DMAC. And I'll actually try and go through each of these individually. Some of the more mundane ones, say, for example, what is very obvious is the fact that in DSEC, you're adding on tissue. And I've just put this DSEC graph for effect, the OCT. The first one is a manually dissected DSEC graph. The second one is a DSEC done with an automated microkeratome. But you'll still see that there is additional tissue that is added on to the eyes. Whereas in DMAC, anatomically, it is as natural as you can get. You take off the desmase and the endothelium, and you replace the desmase and the endothelium. And it is really difficult for someone to tell whether a DMAC has been done in an eye, and it looks almost as good as like an eye that's had cataract surgery with a good phacosurgery. The reason that I took to DMAC, and I think I like DMAC so much, is probably this one. The fact that you have what is published as a lesser risk of rejection following DMAC as compared to DSEC. And in fact, it seems as if DMAC has about an 8-fold reduction in the probability of having a rejection as compared to DSEC. And especially in a country like ours where follow-up is a problem, I think this is a great solution for patients where you would worry about them coming back. And in fact, last week, I saw a couple of patients, both brothers, who came from Maharashtra, I think western part of Vidarbha. And I had done a DMAC for them, for both of them, in 2018. So they had come for their 1-month follow-up visit, and then after that, they didn't come back. And I just saw them a couple of weeks ago. And both of them had 20/20 vision, Fuchs, they were phakic, and they had decided that 1 month after surgery, they don't require any drops, and they'd stopped the steroids. So for 4.5 years, they did not use any steroids. And they came back 4.5 years later with a 20/20 visual acuity and completely clear grafts. Now, which kind of transplant would you expect to have such low risk of rejection? I'm not saying that it's a good idea to stop steroids, but at least it seems as if DMAC has the lowest risk of rejection as compared to all other transplants in our armamentarium, which is the reason why we've been trying to do DMAC post-fail grafts as well. And I would say that relatively decent success. The only problem is the surgical complications of doing a graft in a previous PKI is actually real. So it is not easy to do it in an eye following PK, but that's a discussion for another day. Another reason why DMAC is liked by surgeons as well as patients is because the potential improvement of vision is really good. So you have patients who have excellent visual recovery. Most patients of DMAC will be 20/20 best corrected, and you will have patients who are seeing 20/16 as well. And in fact, there are patients who've had corneal edema following a multifocal IOL. Several of these patients after DMAC, they seem to enjoy the full benefits of a multifocal IOL in the eye. Recently, we have been doing DMAC with toric IOLs as well, and it seems to be extremely predictable from the point of view of visual quality. The IOL power as well is much more predictable in DMAC as compared to DSAC. In DSAC, it is variable, the amount of hyperopia that you induce. It is believed to be an average of about 1.5 diopters, but it can be lower, and it tends to shift over a very long period of time. So you will have changing refraction in patients who have had a cataract surgery along with a DSAC. But in DMAC, the average shift is only about a 0.5 diopters, and it also happens very quickly early on in the post-op course. So you will not find changing refraction in these patients as well. Number 5 is faster visual recovery. And this is again something that I've seen real time. This is a patient post Fuchs dystrophy who had pseudophakic bullous keratopathy after surgery. And then we did DMAC for this patient. And this is day 1, where you see that the cornea is already looking relatively compact. And day 3, where other than the fact that the patient has an air bubble, there is almost no evidence that the patient has had surgery. And the patient in day 3 is already reading 20/25. Which kind of surgery, other than cataract surgery, can give you results like this? I think no other surgery, at least in cornea, forget refractive surgery, can give you results like this. The last reason is the refractive stability after DMAC as well. And this has to do with the width of the incision. In DSAC, the narrowest incision that you can put a graft through, even if you use a Busenglide, without compromising the health of the endothelium, is about 4 millimeters. If you can do it through smaller incisions, but you'll probably be losing endothelial cells. And this does induce a significant amount of astigmatism with this length of incision. Now, if you compare the kind of incisions that you can make in DMAC surgery, where typically the incision is 2.8 millimeters, and you can even put in a graft through a 2.2 injector without compromising the endothelial cell count, you can imagine how DMAC is much more predictable from the point of view of astigmatism as compared to DSAC. So when I ask a group of attendees or of my group, my fellows, of the 5 reasons that I actually gave to pick why you would consider doing DMAC over DSAC, different people pick different reasons because different reasons are important for them. But I think the most important, at least the most common reason that I found is number 1, where you have a lesser risk of rejection and potentially lesser steroids, which actually is a great reason to do DMAC over DSAC surgery. Now, very quickly, in the next 5 minutes or so, we'll talk a little bit about what is the differences in the surgical technique. Again, very quickly, the difference in the surgical technique between DSAC and DMAC depends on the step. In DSAC, there are various ways of preparing the graft. The one that is most accepted is the microkeratome method, where you prepare the graft in the eye bank, most cases. DMAC, now you have pre-stripped grafts that are being supplied by eye banks, and eye banks in the US as well are supplying grafts that are already preloaded in glass tubes. So all the surgeon has to do is to inject the DMAC graft inside the eye, tap, 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 and you're done. It's almost like cataract surgery, and in fact, sometimes it can be even quicker than cataract surgery. But the donor prep in DMAC, again, the very short video, just 30 seconds, is a little different from DSAC. It's done from the endothelial side up and involves direct contact with the endothelium in the periphery and peeling the Descemet's membrane towards the center. And you also tend to have a limited age group of patients that you can take your tissue from, unlike DSAC. you would prefer tissues of donors who are between 40 and 70 years. That's sort of limiting the pool, but still very large pool. And then once you strip your graft, the surgical technique is a little different after that as well. Now, what about DM removal from the host eye? In DSEC, nowadays, we either don't remove the desmes at all, but if the desmes is thickened and has pigments, you would prefer to remove the desmes only in the central visual axis, only about 6 millimeters or so in DSEC surgery. Whereas in DMEC surgery, because overlap of the host and the donor desmes is a risk factor for detachment, it is better to remove as large an area of the desmes membrane as possible and typically ensure that there is no overlap. So about 9 millimeters or so is what you would remove if you're going to be putting an 8 millimeter graft to ensure there is no overlap. So in DMEC, the desmes stripping is always larger than the size of the graft. In DSEC, the desmes stripping is always smaller than the size of the graft. Third difference is incisions. And here in DSEC, what we do is we try to make very long intrastromal incisions so that the inner lip of the incision actually is overlapped by the graft, which is desirable because the graft acts like a valve and you don't have to suture your incisions in most instances. And even the main incision that you use to insert your graft or even do cataract surgery, as you can see here, will be typically longer than your normal cataract incision, as you can see in this video. And the reason why I tend to do that is to be able to overlap the inner incision or inner lip of the incision with your DSEC graft. And I'll show that to you in a second. And this is hugely advantageous because number one, you don't have to suture your incision. Number two, you tend to get a very good tight airfill when you have an overlap of your DSEC overlapping the incision. And third, if you have your DSEC overlap your incision, then typically you will not need to worry about the lenticule coming out of the eye if your pressure is really high because it's already under the incision. Very less chances of that happening. Whereas in DMEC surgery, what happens is you tend to make incisions that are very short. So the reason why this is so is because you want to ensure that the graft does not overlap the inner lip of the incision, and you want to ensure that there is no graft that actually gets stuck in your incision. And even for that reason, the main incision to inject the graft also is typically a little shorter than cataract surgery because you do not want overlap of your DMEC graft over an irregular posterior surface. One of the major shifts in DSEC surgery, in DMEC surgery, has been marking the graft. DSEC, when we started, this is a video from 2007. We used to mark our grafts to ensure that we did not lose orientation. And now in DMEC surgery as well, though DSEC, the majority of cases, we don't mark anymore. In DMEC, we continue to mark because a lot of our patients have poor visibility, and the ability to see the P mark is essential to be able to understand the configuration of your graft. And once you are able to put a little bit of an air and identify the correct orientation of your graft, it is much more of a confidence giver to see that your letter is in the correct orientation. Whereas if you don't mark and you sort of are guessing when your visibility is not so good in case of DMEC surgery. The fifth difference is the loading of the graft. Typically, the graft in DSEC surgery is loaded with the endothelium inwards. You can do the same thing with DMEC as well, but that is not the traditional method how DMEC is done. And once you load the DSEC graft, you put it in with a forceps after you invert your injector and you deliver it inside the eye with the endothelium already facing downwards. So all you have to do is go and put an air bubble and attach the graft. In DMEC, that is not what happens. In DMEC, what happens is you load the graft with the endothelium on the outside, which is the natural configuration of how the graft behaves inside the glass tube. And then when you inject the eye, inject the tube, then the graft inside the eye, you try to place it so that the endothelium is still outwards, and then it's like a U-shaped configuration, and then try to open it up outwards rather than DSEC, where you tend to open it up inwards. So that's how you tend to open up these grafts. Delivering the graft is also different in DSEC and DMEC. In DSEC, there's several techniques, but probably what is most commonly used nowadays is to use the Busin glide or the maculoso inserter to deliver the graft inside the eye. And after you deliver the graft, you also manipulate the graft by directly going and touching the graft and moving it around, and also trying to ensure that it is well centered. With DMEC, you cannot do that. Once you have a graft inside the eye, you cannot go and touch the graft like you see is being done. You have to use fluid forces to ensure that the graft is mobile and moves around, and all your maneuvers actually will happen on the surface of the eye rather than inside the anterior chamber. And this probably is the biggest shift in thought process for someone who's transitioning from DSEC to DMEC surgery. Attachment of the graft in DSEC, you can leave a small air bubble about 8 millimeters, the size of the graft, and usually it'll attach because you also have surface tension at work there. Whereas in DMEC, you have to ensure that you have a complete airfill and complete apposition of your graft to the host. And you also have to ensure that the patient is positioning themselves appropriately for a significant amount of time to ensure that the bubble is apposing your graft towards the stroma. So positioning and graft attachment is really important. So do you think that transitioning from DSEC to DMEC is an easy process? If it was an easy process, you probably would not require a talk to convince you that it probably is worth your time and also worth your effort. And though I've given you a list of reasons why it is important or why it is useful to transition from DSEC to DMEC, one of the thoughts that a lot of trainee surgeons and a lot of surgeons who are at the beginning of their learning curve share is that you need a significant number of cases to be able to get good at DMEC surgery. To a certain extent, this might be true, but then you also ask yourself that after you have done DSEC surgery in a significant number of patients, and your next step should be to think about what can you do better for your patients. And for whatever reason you become a surgeon, whether it's a challenge that you enjoy or it's a problem that you want to solve, you want to explore a procedure that has potentially better outcomes. So when you want to transition to DSEC, to DMEC, the question that actually previous surgeons have asked is, we've seen DMEC surgeons operate, and there are some where it seems as if everything goes like magic, and there are some who struggle. And even the ones who are really good, they've seen them struggle in their OR on their given day. So then the question that always they ask is, I mean, this is such a naturally gifted surgeon. I mean, he has such great surgical hands, but I have seen him struggle with DMEC as well. So what hope do I have? The answer to that question is whether surgeons are actually born gifted or they become gifted because of the amount of time they spend practicing a particular kind of surgery. And when we did a survey amongst attendees for a workshop for endothelial keratoplasty, about 2/3 of them felt that there was a combination of being naturally gifted and experience that made the best surgeons what they are. But again, going back to the question about surgeons being naturally gifted or surgeons becoming good because they actually practice a lot. In our Indian scenario, we never assess any trainee, either at the residency level or even at their MBBS level or at their fellowship level, for their surgical skills. We only ask questions. Whereas medical colleges in Japan, as you can see right here, ask students to put together a piece of sushi or break apart a piece of sushi or stick the wings of a housefly back on itself using super glue under a microscope using forceps to evaluate the surgical dexterity of a surgeon. So, but we never do that. We never evaluate them because we believe that anybody can become a good surgeon as long as they have adequate practice. and which is probably true as well. And if you are a fan of this man, Atul Gawande, and you've read some of his books, especially books like Complications, he clearly mentions that there are clinics around the world who specialize only in one kind of surgery. And the clinic that I went to in Rotterdam, the NEOS, where formerly we had Professor Gerrit Melles do DMEC and do the DMEC courses, and I was fortunate to train and understand DMEC from him. They do only DMEC. If there is a patient who comes to them with cataract and DMEC, they will send the patient back for the cataract surgery to the primary surgeon. And then after that is done, then they'll do DMEC for these patients. So that is the level of specialization. And they typically have the best outcomes of surgery. But having said that, when anybody starts doing any new surgical procedure, and this is something that I became acutely aware of when I was doing DMEC, is that every surgical procedure tends to have something that I like to call a W curve. And the reason why I call it a W curve is because of the fact that when I first started doing the endothelial keratoplasty, 2006 was my first DSEC. And then after having some very good outcomes in DSEC, I realized that I had even better outcomes once I started doing DSAEK. And by 2013, I had thought that, I mean, this is the only kind of surgery that you only require. You don't need to do DMEC. But then curiosity got the better of me and I started doing my DMECs. And in 2014 is when I tried to do my first DMEC. But I still remember that this is a patient who had relatively good visibility. And after my first DMEC, I actually had decent success. I mean, the patient surgery went very well. But then after that, I had a series of complications where I almost stopped doing DMEC surgery. And I thought that, hey, this is not for me. It is too difficult to figure out. And there was this one patient who was a pediatric surgeon who had operated because he had fugues. And I tried DMEC and I had a detachment. And that was really traumatic because I thought, hey, what the hell am I doing? If I can't deliver the outcomes that I'm promising, I better not try this surgery. So this is where I was when I thought that I probably need to go and figure out why everybody else can do DMEC, but I can't do DMEC. And that is when I went for my course. But then I realized that the W curve for surgery starts when you start exploring any new surgery and think that, let me see if I can do it. But then after you have some beginner's luck, then you figure out that this is not an easy surgery once you start having complications down the line. But if you keep at it and surmount those complications, you will get better at this surgery. And then you'll think that, hey, you figure out all the nuances of surgery and you become better. And then you become overconfident. And then you have your second round of complications. And only after you go through your second dip of complications, will you actually become a gifted and a truly accomplished surgeon in any kind of surgical sphere. And this, I think, is true for most surgeries that I have seen myself. And also I have seen other surgeons also transition to. And I think this is probably something that you should invest time in to become good at DMEC as well. So ensure that you are able to get through those troughs so that you keep practicing DMEC surgery. And when you get to where you are at the top, also remember that because of access to tissues, access to standby tissues, everybody's W curve is going to be different. There's some for whom it's going to be very broad. There's some for whom it's going to be very narrow. So it all depends on where you are placed on your access to tissue. But remember that there are some difficulties during transition, but these usually are in the first 5 to 10 cases. Beyond that, you will figure out most things yourself and your W curve can be completed within 10 cases of DMEC. Now, having said that, where would I still do DSEC surgery in a patient who has pseudoaphakic corneal edema? I would still do DSEC if there is very poor visibility, or if the patient cannot lie still for a long time, or if the anterior segment anatomy is very disrupted and there's a lot of pus, or if the graft-nose junction is very poor, or in cases where patient has limited vision potential and DMEC really won't make much of a difference. I will continue to do DSEC. But otherwise, in every other case, I would try to attempt to do a DSEC because it is, along with all those other reasons, it is also so much more fun. Thank you very much for your attention. And I hope several of you would have transitioned to DMEC in the near future. Thank you, Sahil. Thank you, Abhishek, again.
Thanks a lot, sir. Thank you for taking out your precious time. Quick question. What about ACIOL, vitrectomized eye with scleral fixated? Are these also difficult with DMEC or DSEC? What would be the procedure of choice for those?
Yeah, I would do a DSEC in patients. I mean, in the initial phase where, like the old saying goes, right, to a hammer, everything looks like a nail. So if you see a patient who has corneal edema, you want to do DMEC in that. And you don't pay attention to the other problems like a deep chamber, high myope, ACIOL, whatever. You try to do DMEC in everything. But then you realize with time that it's not worth it. It's not worth the time or the effort, or the outcome that you deliver to the patient also is not worth it. And that's when you become choosy. So in an ACIOL now, I will do a DSEC. In an SFIOL or an iris fixated lens, can you do a DMEC? You probably can. It's possible. But the amount of maneuvering and the amount of surgical manipulation that you will have to do in cases like this, you'll probably lose more endothelial cells than if you do a clean DSEC. So in cases like that, it's probably better to do a DSEC than a DMEC.
Thank you, Dr. Praveen, and it was really a wonderful talk. And like you said, I hope we have converted a lot of patients and a lot of surgeons to shift from DSEC and try out DMEC. And with that, we come to the end of this session. And I thank all the panelists, all the faculty members, all the participants here for the wonderful talks, for the wonderful discussion, and for the wonderful insights into their respective fields and also into other fields. And I hope to see you all soon in some in Kerakon. And all the best for everything you do, and good night.
Good night.
Thanks, everyone.
Thank you.
Good
Thank
night.
you.
Thank you, our host, for a wonderful evening. Thank you.